The take-home message is that everybody requires cancer screening and start screening at the age of 45. Colonoscopy and fit examination are tier number one in the screening program test. Accurate stratification is necessary to stratify patient. High quality screening exam, high quality colonoscopy is important. High-risk individuals should have genetic evaluation, and health authority in the kingdom are streaming screening program. 20 months. Thank you.
Well, thank you, Dr. Ahmed. Thank you very much for this fruitful presentation. And I think that because of time, we will leave the question at the end of the morning session. Thank you.
So we will move to the next presentation. I would like to welcome Dr. Abdulrahman Al-Fada. He's the Director of Endoscopy Unit, Consultant Gastroenterologist and Therapeutic Endoscopist. He's the Program Director of Gastroenterology Fellowship, Program Director Gastroenterology and Hepatology Fellowship, and Director of Advanced Therapeutic Endoscopy Program, and also the Pancreatobiliary Program from King Faisal Specialist Hospital, Riyadh. Welcome, Dr. Abdulrahman.
Thank you very much for this great introduction, and I'm happy to be a part of this great oncology conference that have been adopted in El Musa Specialist Hospital. As we're talking about a colorectal program, Dr. Ahmed alluded very nicely about the colorectal cancer screening program and the effort that have been done so far. So I'm going to complete the next 20 minutes talking about what if you have a polyp or you have an early cancer screening, how you can treat this endoscopically. Some figures from my hospital here, King Faisal Hospital in Riyadh. The top right is the hospital. Our endoscopy unit is in the down left side in the 5th floor, and the one on the right is a part of the recovery area in our endoscopy unit. So here are my disclosures. As Dr. Ahmed alluded, the colorectal cancer is the second most common cause of cancer in women, and it's the third most common in men, accounting around a brief figure of 10%, and it's the most common cause of cancer-related death all over the world. As we have more cases discovered in the West, in the East, we are having more colorectal cancer discovered, probably due to change in the environmental factors, the pollutions and others, increased rate of smoking and other risk factors, as well as the increase of the colorectal cancer screening programs that have been adopted in many private and governmental hospitals. Interestingly, around a quarter of cases of colorectal cancer can be prevented by having a good surveillance program, by doing more physical activity, healthy diet and food, and reduce smoking and alcohol. And here there is the role of the probably different hospitals to start adopting an effective colorectal cancer screening program that looks into early stages that can be treated or even preventing of the cancer itself. Now, if we talk about the population, as Dr. Ahmed demonstrated clearly, the recommendation is from 50, and it ends at 75. The task force, the United States Task Force Group, have been reducing the age up to 45 due to the increased incidence of colorectal cancer. In Saudi, we're still doing at 50, but maybe in high-risk population, patients who's having a family history of colorectal cancer, we do start earlier a little bit according to the individualized discussion between the patient and the doctor himself. There are many challenges for colorectal screening program. I've been a part for this in the Ministry of Health for the last 5 years. There are personal benefit beliefs that they don't want to do the test. They fear from the test itself. Awareness of the program is as well a problem. It's not always that the primary care physicians have been sending the patient for colorectal screening, and there are financial barriers for insurance covering and others still taking place in the country itself. So if we look into the staging of colorectal cancer, how can we stage? Staging is very important as it looks into the disease that can be treated endoscopically and the diseases that can be treated surgically. So we use endoscopy to differentiate early lesions, the T1N0, the T2N0, T3 lesions from other lesions that need surgical resection as well. There are still several meta-analyses that looked into this. I'm not going to go in details, but endoscopic ultrasound have been the best modality to look into the early polyps or carcinomas in situ, and it has a sensitivity of around 98%. There are two main roles for endoscopy in colorectal cancer. The first is that we can resect early lesion endoscopically without referring those patients for surgery, and then we can manage malignant colonic obstruction by putting different stenting modalities. If we look into the colorectal lesions, it varies widely across the globe. It's counted to be 10% in those who had a sigmoidoscopy and 25% in those who had colonoscopy. And most of these lesions can be treated with standard technique, but I'm here to talk about probably a little bit of advanced endoscopic technique, including endoscopic mucosal resection and endoscopic submucosal dissection. The advantage of these two techniques is that it allows wider and deeper resection margins of the lesion. It allows an in-block removal of lesions for more detailed pathology, and probably it can give a curative intent for early neoplastic GI lesions. When we do endoscopy, we have a classification for different polyps, as each polyp has its own technique and modality for removal. This is the Paris classifications that go into the polyp classification. As well, we use special imaging technique, the MBI1 and others, to look into the color, the blood vessel pattern, the surface pattern, and to decide what kind of polyp. Is this benign? Is this malignant? Do we have to treat? Do we don't have to treat? And so far. Now, the first thing is endoscopic mucosal resection. I'm going to talk about it. It was developed around 40 years back in Japan. It's safe and effective. It doesn't require lots of training, as it can be adopted after doing 50 or 60 special EMR. The goal is to remove the lesion completely without keeping any residual tumor around and without trying to do other EMR. If you want to do EMR, you have to have a full care set and to make sure that you have an effective procedure and to prevent any possible complications. Here are some of the tools that we use in our endoscopy unit, including the processor, the ectosurgical unit, the injectates, different kind of needles, caps, and maybe coagulation forceps if needed as well. Now, why do we inject below? Because it can create a cushion between the mucosa and the muscle layer, and then it's safer to remove the polyp without injuring the muscle layer or causing a perforation as well. Now, I'm not going to go into this in details, but now there are great advances in the injectate or the material that we inject below the polyp to remove it, and these viscous solutions have been shown better than the one that we use usually, which is the normal saline. Epinephrine usage, whether it's beneficial or no, this is the largest prospective multi-trial that looked into this for large polyps of more than 10 millimeter, and there is basically no benefit of epinephrine injection before removing the lesion itself. There are different type of snares. Each lesion have to have its own snare, and it depends on the colonoscopist what kind of snare that he's going to use, and the type of the polyp that it's there as well. Now, this is like probably 2 years back with a patient who have been referred for me for screening colonoscopy, and as per Paris classification, he had a Paris type 2A lesion, so it's a flat lesion that it's elevated, and what we are doing here is trying to elevate the lesion to create a cushion between the mucosa and the muscle layer, so all this bluish thing that comes below is the injectate. It's very important to create a good cushion so that you prevent the electrosurgical trauma that might happen into the mucosa. Then this is like probably 1.5 centimeter or a little bit less. This is our snare going into the lesion itself, and we're trying to grab this. Trying to run it faster a little bit. So here is the snare, cutting the lesion, and now after the lesion have been removed, as you can see here, now this is the bluish thing, means that you're safe, you're good, you don't have a deep muscle layer. Then after that, you are going to close this. Now there are many ways to close it, either using surgical clips or using a suturing device. Suturing device is a bit expensive, so we used to close it using clips. And I may show you the final look of the lesion after clipping, and I'm going to talk about clipping in a while if it's useful or no. This is other lesion that's lateral spreading tumor of a granular type in the distal ascending colon using special imaging technique. Sorry. Elevating the lesion again, the same technique, basically going through all the tumor. It's very important to look into the all margins and make sure that you are elevating the whole margins. Snare is to be applied after this, and this is a 3 centimeter snare for this kind of lesion. After that, we apply, we close the snare, apply electrocautery, and just remove it. And we basically do what we do before, and we clip. Now there is a small remnant of lesion here that I need to snare again and take it off because of remnants, and they recommended it to do screening after 6 months procedure. Now these are techniques for gastroenterologists, keeping the scope stable. It needs quiet training, keeping the position at 6 o'clock, eliminate pooling of fluid, and other techniques. Now we are using what we call endoscopic full thickness resection. That means if you have a lesion going down into the muscle layer, you can just apply co-grasper and remove and pull the lesion, then band, then cut below the band. So this gives you a full thickness resection up to the serosa for early gastric cancer. This is a target sign. If you have this, it means that you perforate after polypectomy, so you have to look into the patient carefully after that. Bleeding is a common in EMR. It happens around 12%, and the most important factor of having bleeding after polypectomy if you do less EMR. So if it's less than 75, the odds ratio is around 4%. So they're going to have 4 times bleeding than the regular, than the expert kind of colonoscopist. Delayed bleeding can happen, and the most important factor is lesions on the right side of the colon itself. Looking into the clipping, this is the largest multicenter randomized trial involved in 17 countries, looking at around 1,000 of polyps. The primary outcome to look into the bleeding of after doing polypectomy with clipping and without clipping. And as you can see here, maybe the pointer is not very clear, but if you can see, those who had clipping, they have a bleeding rate of 3.5% compared to those who have 7%. So if you remove a polyp and you have clips available, please do clip those polyps to prevent bleeding. Many questions that are unanswered, so I'm gonna move. Unfortunately, with more advanced endoscopic procedure, yet more patients are referred for surgery. In the 2000s, there was like 6% of those referred. Now we have around 15 to 20% that have been referred. It's obvious that doing polypectomy using colonoscopy is much cheaper than doing a colonoscopy itself. I mean surgery for a polyp, not a cancer I'm talking in this case. This is number one. The number two is the ESD. ESD is more advanced technique used for colorectal cancer, where you go and you dissect the lesion from the submucosal space. We started this program in 2017, and we had around 143 lesions in up to quarter two removed by this step. Basically, when you mark the tumor using a coagulation, you inject, then you use a special needle to cut below the lesion itself, and you remove the whole polyp in one block rather than having a piecemeal resection. There are many kinds of needles. You can use what needle you have been trained on, and with time, you're gonna probably select your best needle. Many solutions have been tried. We use CO2 because if there is a perforation, it can be absorbed fast. And for upper GI, we use full sedation. With colonoscopy, we use deep sedation. When to consider ESD over EMR, there are several patient factors, doctor factors, lesion factors that makes ESD is superior to EMR. We usually we show the patient the picture, and we said, well, you have two types of procedures. We think that this lesion is deep a little bit, so maybe we'll do ESD rather than EMR. And after having a mutual agreement, we continue. This is the last slide, looking into a lesion who been involving the transverse colon. And as you can see, we inject here and we elevate. And what is different here is that we use a special needle here, as you can see it in the lower part here, cutting the wall of the lumen itself through the submucosa, trying to go across the whole wall of the around the wall of the submucosa. And now we are entering between the mucosa and the submucosal space, trying to dissect with the needle the tumor, which is in the upper part, or the pre-malignant polyp, which is in the upper part. This procedure needs more training. It has more complications. You have to undergo probably a fellowship program or a training program for 3 months or so to have this been done in a safe manner. Now, what you'll see here different is that this lesion is resected in one piece, and you don't have to do it. So this is the polyp, or the early, there was a carcinoma in situ actually in pathology. So this is the last part where we end and we finish our cutting of that lateral growing tumor, and then we will have a lesion that have been showing the submucosa and clearance. We do surveillance for those patients as well after 6 months. If there is no recurrence, we do it after a year and 1 year. So you can see in the lower part here, this is basically the whole lesion have been excised. We send this for the pathologist, and then we see. There are people who clip ESD lesions. I don't clip it because the evidence is not strong, and we have other parameters that looked into this, looking into solutions that can prevent bleeding post-ESD procedure rather than EMR. So complications are basically the same. So to conclude, comparing the endoscopic mucosal resection and the endoscopic submucosal dissection, it's obviously that the in-block resection in ESD is higher than the EMR. The perforation rate, because you're going deeper in ESD, is higher than in EMR. The delayed bleeding is almost similar. There is no much difference. Procedure time for endoscopic submucosal dissection is higher. You can start doing a procedure in 3-4 hours. Then after maybe 10-15 cases, it's going to be reduced a little bit. The average time, according to this old study by a Japanese group, very well experienced, is around 1.5 hours to remove a 3 centimeter polyp by ESD. So, dear Mr. Chairman and audience, the take-home messages is that colorectal cancer, as Dr. Ahmed Al-Akwa alluded, is increasing globally. The need of an effective screening programs are mandatory to reduce colorectal cancer incident. There are many endoscopic techniques that have been grown, and we'll hear more endoscopic technique in the future as well. to look for colorectal precancerous lesions and how to effectively treat them. And I didn't talk about stenting, but maybe this, inshallah, can be other talk when we talk about the role of stenting, palliating, or bridging for surgery after this. And by this, I'll thank you all.
Thank you, Dr. Abdurrahman, for this very nice presentation. We will also leave the discussion for later for the question and answers. I would like to welcome our next speaker, Dr. Muhammad Al-Qahtani from King Fahd Specialist Hospital, Dammam. Dr. Muhammad Al-Qahtani actually does not need an introduction, mashallah. He's the director of the Multi-Organ Transplant Center at King Fahd Specialist Hospital, Dammam. Dr. Al-Qahtani is a senior HPB and multi-organ transplant consultant surgeon. He's the elected president of the Pan-Arab Liver Transplantation Society, PALTS. He's also the chairman of the National Liver Transplantation Committee, SCOT. And he is one of the founding members of the multi-organ transplant program at King Fahd Specialist Hospital, Dammam, which was launched in 2008. In 2016, he also established the renal transplant program at King Abdullah Medical City, Mecca, and performed its first case in April of 2017. And I'm just trying to be short with all of his achievements. He has much more than that. أهلا بك دكتور قحطاني. تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, thank you so much, Dr. Mamdouh, for the nice introduction. I really appreciate it. And again, it's a teamwork. It's not only one-man show. Thank you so much for the organizing committee. Maybe it's not interesting for the those who are not surgeons to talk about the surgical management of colorectal cancer liver metastasis. I'll try, inshallah, to be on time. As we know that the estimated number of new cases in 2020 in Saudi Arabia for both sexes, male and females, if you could see here, you know, the percentage of liver cancer, which accounts for almost 4.1%. Of course, the highest rate is colorectal cancer, which is 14.4%. In the US, around 150,000 new cases have been diagnosed every year. 50% of those will develop liver metastasis down the road. Only 20% will be candidate for potentially curative resection. And the hepatic resection, as we all know, is the treatment of choice for colorectal cancer liver metastasis. The 5-year survival doubling from 30% in 1990 to almost 60% in the last 20 years, and this, of course, because of the advances in the treatment and also medical and also imaging. The strategy to deal with colorectal cancer liver metastasis, of course, you need a multidisciplinary approach like any other disease, and the patient selection is very important actually to achieve the best perioperative period and also to achieve a long-term oncological outcome. Patient selection, again, you have the patient's factor, disease factor, and the patient's factors, maybe you have resectable disease, but on the other hand, because of high morbidity and perioperative comorbidity, the patient will not be able to go for resection. And in those cases, you have to have some sort of medical optimization. The tumor factors, as we all know, the tumor biology will affect the overall survival and the tumor also location if you compare the right-sided with left-sided colon cancer. The anatomic factor also, the positive margin, we all know that negative margin is negative margin, whether it's 1 millimeter or 2 millimeter. But in JAMA surgery in August 2022, they have published this paper, and using the artificial intelligence, they found that a negative margin of 7 millimeter will result or will maximize the 5-year death, will decrease the 5-year death probability. The anatomic factor for all surgeons, you need to achieve the following. You need to have good inflow in the form of having portal vein inflow, arterial inflow, and of course you have the hepatic venous outflow with adequate biliary drainage. And what is left behind is actually more important than what has been resected. So in those patients, I mean normal patients, you need at least 20 to 25% of what's called future liver remnant. And in those patients who underwent or who had chemotherapy, this goes up to 40 to 50% future liver remnant because of C2 hepatitis post-chemotherapy. What has been changed, as I have mentioned earlier, is the advances in imaging, safer chemotherapeutic agents, safe surgery, and enrollment in clinical trials. Imaging, I wouldn't spend that much, but we actually prefer the MRI with a sensitivity of 81% and specificity of 97%. PET scan, if you have increased CEA and you cannot find, the tumor in the liver or small tumor in the liver that cannot explain the increase in the CEA, you need to proceed with PET scan. Intraoperative ultrasound is very important, as even more accurate than MRI, as we use it intraoperatively. I wouldn't talk about chemotherapy. The drawback of neoadjuvant chemotherapy is the liver damage, as I have mentioned, and complete radiological response. What are the surgical options? We have many surgical options, and the most important is to have what's called parenchymal sparing hepatectomy to preserve as much as you can from the liver parenchyma, because those patients, in around 50 to 60%, they will have recurrence of the disease in the liver, so you need to spare as much as you can for the future resection. We have what's called two-stage hepatectomy in the form of ALBS, which is called associated liver partition and portal vein ligation for stage hepatectomy, repeat hepatectomy for recurrence, minimally invasive liver resection, hepatic arterial infusion chemotherapy, and liver transplantation for a few subset of patients. The approach, selection of surgical approach, if you have a locally advanced rectal cancer with resectable liver lesions, then in those patients you need to start with neoadjuvant chemotherapy, liver resection, especially if the liver lesion is located in a very difficult anatomical site, where if you delay the patient or if the patient has any complications in the form of leak post-colonic resection, this might result in delay of liver resection. So in those subset of patients, preferable to go ahead with liver surgery, and then after that you deal with the primary. A delayed liver resection would worsen chemotherapy-induced liver changes and post-op liver failure, and we have seen it actually in one case in our hospital. The majority of patients post-neoadjuvant chemotherapy, even though if they will have complete radiological response, still in around 83 to 85% of those patients, still they will have viable disease. On the other hand, that means the complete pathological response is only noticed in 15% of patients post-chemotherapy. So if you can resect post-neoadjuvant chemotherapy, that's well and good. The parenchymal sparing hepatectomy, as I have mentioned, as you could see here in the right side of the screen, you see what's called mesohepatectomy, where you need to remove segment 4B, 4A with part of segment 5 and 8, sparing as much as you can from the liver parenchyma. And here, in one of our cases, the tumor was very close to the right portal vein, so the right portal vein is completely skeletonized, trying to keep as much as you can of the right lobe, because as we all know, if you take or ligate the right portal vein, then the whole right lobe has to come out. The 5-year survival of the stage resection is 32%, and the median survival is 39.6 months, and resectable disease survival is 18 to 22 months. The two-stage hepatectomy, in the first stage you go in, especially if you will go with the colorectal cancer, if they will plan to remove the primary first, you go in, you try your best to resect or to wedge resect as much as you can, especially from the left side. On the right side, you do portal vein ligation, you leave the arterial inflow, biliary drainage, as well as the hepatic outflow. And recently they talk about LFD, that I will talk about it later on. You do the partition, and in the second stage, you remove the right lobe. The advantage of this stage liver resection, you will have what's called hypertrophy of the left lateral segment, which will be enough as a future liver remnant for the patient post-op. The LVD, or what's called liver venous deprivation technique, what you have done in the Alps, you will add to it hepatic outflow ligation, which means you take the right portal vein or you embolize it by interventional radiology, and you add to it is embolization or ligation of the right hepatic vein as well as the middle hepatic vein, and this is called the liver venous deprivation. Results, the future liver remnant will increase in the function and in the volume within only 7 days post ligation. The redo liver resection, 50 to 70% of patients post resection will develop recurrence. The 5-year survival is 20 to 80%. I will just go through a few cases that have been done in our center. Dr. Mamdouh was part of the team at that time. If you could see those patients, actually this patient is having multiple colorectal cancer liver metastasis involving both lobes, the right and the left lobe. And if you could appreciate, unfortunately I don't have the, if you could appreciate, you know, the big lesions on the right lobe involving almost hepatic veins as well as the portal vein. So the patient deemed unresectable, received 6 cycles of neoadjuvant chemotherapy. And then this is the result, which is excellent response to chemotherapy. The tumor size is getting less in size, or smaller in size, sorry. The patient was taken to OR, underwent initially low anterior resection and lobe ileostomy. We did intraoperative ultrasound. At the same time, we did right portal vein ligation, segment 3 and 4B resection, and RFA of segment 4A. So we have almost dealt with all segments in the first session. And this is the right portal vein ligation and RFA of segment 4A and 4B. The second stage, he underwent right hepatectomy and closure of the stoma. This is in the second stage. As you could see here, the right lobe has been resected. The segment 4A, the result of the RFA in the first stage. And if you could see, the left lobe or the contralateral side has got hypertrophied. For the same patient, after 1 year, developed another lesion in the left lateral segment or in the remnant liver, and also in segment 4A. So what we have done, we took him back to OR and we have done redo resection after 1 year. After 18 months from the second resection, the MRI showed lesion in the left lobe close to the atrium. So we took him again for the third time to OR, exploration and embolization, alcohol ablation, and then adjuvant chemotherapy. This is the successful intra-op alcohol ablation for the same patient. After 9 months, again recurrence of the same lesion. So we took him back to OR because the lesion was very close to the atrium, and we did exploration in the OR with microwave ablation, as it's more potent or more effective than alcohol ablation. After 7 months for the same patient, progression of the size of the same lesion, so we did another intraoperative microwave ablation. He's still alive, almost 9 or 10 years, so we will consider him cured from the disease. The second patient, as you could see here, those are the lesions that was in 2012, multiple lesions in the right and the left lobe. And the problem here, unfortunately, I cannot point out the lesion. But unfortunately, if you look at the left side, the lesion is abutting the left portal vein. And here in this picture, you know, very close also to the middle hepatic vein, multiple lesions in the right lobe. So lesions between the left and the middle hepatic vein in segment 4A, so it's enveloping the whole liver. So stage 1, this patient received neoadjuvant chemotherapy taken to OR, colon and anterior abdominal wall resection with an intraoperative ultrasound. And at the same session, we have taken the right portal vein. And then, as you could see here, the ligation of the right portal vein, the left lateral segment has got hypertrophied. And the second stage, that was after 2 to 3 weeks, we took the patients with the help and the guidance of intraoperative Doppler ultrasound. We were able to monitor the left portal vein to guide our resection, and we ended up by doing right trisegmentectomy, or removing of segment 5, 8, 6, 7, and segment 4 as well. When I was preparing the presentation, I took the number, and fortunately she's still alive. She's almost now 10 years post-resection, so we would consider this patient as a cured patient. As you could appreciate here, the significant hypertrophy of the left lateral segment. The outcome of liver resection for colorectal cancer metastasis, mortality is 5%, morbidity 20 to 50%. The 5-year survival is almost 40%, 10 years is 26%, and the median survival from 24 to 46 months. The ALBs, we have done like 8 or 9 cases. I have mentioned about the ALBs is to have the partition, ligation of the right portal vein. This will allow hypertrophy of the left lateral segment, and those are the cases that have been done with the ALBs technique. If you could see here, this is the intraoperative picture that has been taken showing the significant hypertrophy or enlargement in the left lateral segment or the picture liver remnant. This patient, actually, he's the only patient who underwent liver transplantation as a treatment of choice for colorectal cancer liver metastasis. And it was the first case and the only case, I guess, in Saudi Arabia. This patient actually received tons of chemotherapy as a neoadjuvant, in the neoadjuvant setting. He was having multiple lesions in both lobes. He's 36 years old, Saudi male. So when we took him to OR, because of the steatohepatitis, he underwent, we did CT volumetry. The remnant was more than 40%, but the quality was not that great. So he underwent right hepatectomy in October 2017, but unfortunately, he had acute liver failure immediately post-op. So we have to negotiate with the head of Saudi Center for Organ Transplantation. He told me it's not the standard, we don't have enough pool for our patients, hepatitis patient, hepatocellular carcinoma patient. I told him, listen, he's a young chap. He is having acute liver failure in the ICU, and we need the liver transplant actually as a salvage procedure. So after a lot of discussion, he agreed. We got the liver, and this was in 2017, and we did the liver transplant. This is actually the transplanted liver here in 2018. The problem is the immunosuppression, so we had to have multiple multidisciplinary meetings to agree on the protocol for immunosuppression. Now he's already 2017, so he's already 5 years post-liver transplant. He's doing very well with no recurrence, with stable or normal CEA. So, in summary, the strategy and timing of management or surgical management of colorectal cancer liver metastasis, it's a multidisciplinary team approach or management where you need to have the medical oncologist, colorectal surgeon, hepatobiliary surgeon, interventional radiology, radiation oncologist, thoracic surgeon, and of course the other supporting services to have the better outcome, inshallah. Thank you so much.
Thank you, Dr. Gahtani, for this very nice presentation.
So I'll introduce the next speaker. It gives me a great pleasure to introduce my friend and colleague, Dr. Amin Umair. He's one of the best radiation oncologists in Saudi Arabia, and he's an expert in stereotactic radiotherapy. He graduated from University of Toronto, Canada, where he did his residency and fellowship. And currently he's working at King Faisal Specialist Hospital, and he recently joined Al Musa Hospital in the radiation oncology team. So without further ado, Dr. Amin, the floor is yours.
Thank you very much, Dr. Sameh, for this kind introduction. Also, I would like to thank the organizing and scientific committee for holding up this very successful meeting. Also, congratulations to Al Musa Hospital for holding this event. So I was asked to talk about stereotactic body radiotherapy, so-called SBRT, in oligometastatic colorectal cancer. So the presentation will be about oligometastasis in general, with focus on metastatic colorectal cancer. So in any cancer, on any oncology staging system, you can have either two extremes of staging and nothing in between. So you either have loco-regional disease, which is treated with a curative intent. In the other extreme of staging, you have metastatic disease, which is typically treated with a palliative intent, and there is no intent to cure this patient. And this patient with metastasis is deemed incurable regardless of the size or number of metastases. So let me walk you through one of the first ever case report. This is almost 83 years ago. Particularly in 1939, a case report of a patient with renal cell carcinoma treated with a nephrectomy. After a long time, he developed lung lesion. And this might be regarded as a new lung cancer primary because patient was treated with lobectomy as opposed to segmentectomy. And interestingly, the pathology came back as metastatic renal cell carcinoma, not a lung primary. And this was the first ever published case of incidentally cured patient with oligometastasis. This is almost 83 years ago. So the concept of oligometastasis is well known before it was formally published in JCO in 1995. And in 1995, in this publication, they defined oligometastasis as a disease state between loco-regional confined and widely metastatic disease, where the number of metastases are truly limited in number and location. And as most of you know, there is no international consensus definition of number of metastases, but most of initially started with single mets, then it stretched to 3, and now even 5 metastases is acceptable. So this is one of the most controversial staging state in oncology. So does this oligometastatic state exist, or in the other word, can we cure patient with oligometastasis? And the answer is yes. Dr. Mohammed Al-Qahtani was just alluded to and showed us several cases that was cured from colorectal cancer primary and liver metastasis. We know that, but you always can argue against this by saying colorectal carcinoma is very unique. It's drained directly into a portovenous draining system, so it's not a real distant metastasis. But then how to explain other surgical series? For instance, non-small cell lung cancer primary, if they have single metastasis and you treat both surgically, then the 5 years overall survival is ranging between 10 to 20%. So we know that surgery can potentially cure patients with oligometastasis. How about other local ablative therapy? Say, how about stereotactic body radiation therapy, or SBRT, or SABR, stereotactic ablative radiation therapy? The answer is yes. SBRT can potentially cure patients with oligometastasis. This paper published in JCO in 2013. This table summarized some of extra cranial oligometastasis, different retrospective series. I'm focusing on colorectal cancer. So for instance, this publication for patients with colorectal cancer primary, lung, liver, and adrenal metastasis showed that 2 years overall survival, 38%, and 5 years overall survival, 13%. Another colorectal cancer series from east of Asia, also they report 2 years overall survival up to 49%. So there are some subset of patients can be cured with oligometastasis, but this is a retrospective trial. And this review article focused mainly on common site for SBRT lung, liver, but this is another published article in the Lancet Oncology, where they actually showed us some rare site of that we treat with SBRT, like lymph node. And this 2 series included patients with rectal and colon cancer primary, and pelvic, presacral lymph node, and adrenal gland. And bottom line from this trial is that the local control with SBRT is very high, almost 80%. And you can potentially cure small subset of patients, up to 20% with this technique with minimum toxicity. I'll walk you through cases that we did a long time ago. For instance, this is a 60-year-old gentleman. He's a physician. He was developed lung cancer. This is a lung primary in the left lower lobe. And he had single isolated T3 spine metastasis. I treated him with stereotactic radiation therapy back in February 2015. Shortly after the treatment, we did a PET scan follow-up, and he had complete metabolic response. So this is the baseline scan before the treatment. You can see the lung lesion and the spine lesion, and all subsequent follow-up with PET CT showed complete metabolic response, and he did very well. I saw him last summer. Another case of this is not really standard of care because this patient had a spinal cord compression from breast carcinoma primary. You can see there is a significant amount of vertebral body disease, paraspinal extension, but also epidural disease extension causing cord compression, significant mass effect on the spinal cord. You can see the spinal cord is pushed significantly by the epidural disease. And the epidural involvement is done more than 180. Typically, those patients need a surgery, which improve the survival, improve the outcome, as per the Batchel trial, followed by radiation therapy. But she refused surgery. So we treated her with SBRT back in April 2014. And this is her pre-treatment sagittal MRI spine. And you can see almost complete response on the segment that was treated. And when it comes to the cord, you can see there is significant disease in the epidural pushing the cord to the other side. The cord now is completely decompressed, it's relaxed, and patient had very long disease-free survival. So, but this is all what I show you is some anecdotal cases that I treat and you treat, and some retrospective trial. And I guess the real question is, do we have randomized controlled trial for the use of SBRT in oligometastasis? And the answer is yes, we have quite few. So basically, the well-known SABR-COMET trial is the first ever phase 2 randomized controlled trial. Not only first randomized trial, but first randomized trial with the primary endpoint being the overall survival. It's a multi-center international trial led by Dr. David Palma. So they allowed up to 5 metastases. However, most patients had 1 to 3 metastases. I'll show you this in a minute. And the randomization is 2 to 1. So one patient get standard palliative care, so 20-in-5 or 30-in-10 or even 8 gray single fraction, and the other arm is getting the SBRT. So 2 patients get SBRT, 1 patient getting conventional palliative treatment. The primary endpoint, as I mentioned, is the overall survival, and the secondary endpoint is listed here. So initially it was published in Lancet, but then the update is in JCO. So this is the inclusion and exclusion criteria from this trial summarized in this table. The most important thing is they defined oligometastasis here by up to 5 metastases. However, majority of patients, more than 90% of patients had 1 to 3 metastases. Minority have more than 3 metastases. The commonest metastatic site treated with SBRT is lung. And for the colorectal, there is a quite good number of patients with colorectal carcinoma primary. So the result of this trial, as you can see in the Kaplan-Meier curve, showed significant improvement in overall survival, huge separation of the curve between the SBRT arm, which is in the red, and the conventional arm, which is in the blue. Also, it showed significant improvement in progression-free survival in favor of SBRT. There are some, the treatment was well tolerated, but there's 3 patients who died from SBRT, and they analyzed whether this affect the quality of life negatively, but there is no difference between the 2 treatment arms in terms of physical, emotional, social, and functional outcome. And when they lumped all the quality of life score, also was not, there is no significant difference. So although there are few cases of expected death from SBRT, but this was not affecting the quality of life negatively. So the limitation of this randomized phase 2 trial is it's a phase 2. So now the SABR-COMET group are doing phase 3 randomized controlled trial, so it's ongoing. The other problem is it's not a histology-specific trial, and let me talk about histology-specific trial focusing on colorectal carcinoma primary. So before that, the colorectal carcinoma is one of the commonest primary tumor, but also it's not uncommon to see metastasis as listed here, either metastasis at presentation or subsequently. The ESMO published this practical guideline updated last month, where they listed 2 approaches of treating oligometastatic disease. Most of us in favor of the first approach, to start with induction chemotherapy to test the behavior and biology of the tumor. And if patients respond well, then you can go aggressively and treat the oligometastatic side. However, there are some centers they do upfront local ablative therapy, whether surgery, metastacectomy, or SBRT, then give chemotherapy, which is the least favorable approach. In terms of randomized trial for histology-specific colorectal carcinoma with metastasis, there is 2 trials, Oliver trial and the NCT 028-20194. But before that, in the ESMO guideline review, they estimated the chance of local control for oligometastatic disease from colorectal carcinoma primary ranging between 30 to 90%. And there is no grade 3 toxicity or more. So what's predict local failure? Of course, size of metastasis. If you deliver low biological equivalent dose by SPRT, this indicates maybe more chance of failure. But also, you need to have a center that equipped and ready to treat with oligometastasis. And this is Dr. Sam Hashim might explain this better than me. He trained, he did fellowship in liver SPRT because majority of those cases are liver metastasis from colorectal cancer primary. So he did his fellowship with Dr. Dawson, one of the world figure in SPRT. So very important to have emotion management and equipment that's ready to start SPRT. And he told me that at Al Musa Hospital, they have fully equipped. Yesterday he told us that they have fully equipped and they're ready to start the SPRT cases. So regarding the 2 randomized trial, unfortunately, it's closed early because of low accrual. So Oliver, or the French trial, as well as the randomized trial comparing SBRT versus microwave ablation, was closed because of low accrual. So moving on and talking about histology-specific randomized control trial for use of oligometastasis, for use of SBRT and oligometastasis, I'll switch gear now and talk about lung cancer primary. Dr. Iyengar trial is a phase 2 randomized trial, and they start with, as I mentioned, with induction chemotherapy for stage 4 non-small cell lung cancer. After that, they randomize patient, one arm getting the standard of care maintenance therapy, and the other arm is getting SBRT. And it's a 1-to-1 randomization, a small number of patients, and the trial was stopped early by Data Safety Monitoring Committee because of striking difference in progression-free survival in favor of SBRT. The main criticism of this trial is the small sample size. So I'll talk about large phase 2 randomized trial by Dr. Daniel Gomez, where he did the same design of the previous trial, but here, not every single patient getting SBRT. Actually, it's a local consolidative therapy. So it could be surgery or SBRT or other ablative therapy, but 60% of patients is getting SBRT. And again, the trial showed striking difference in progression-free survival in favor of SBRT. Not only this, but it showed interesting thing that SBRT delayed the onset of new metastasis to be appeared. And the update of this trial in JCO, they also reported significant benefit in terms of overall survival in favor of SBRT. Switch gear from lung cancer to prostate cancer, where they actually do a randomized trial for oligometastatic prostate cancer. And it's 2-to-1 randomization, 2 patients getting SBRT, 1 patient getting observation. The primary endpoint is disease progression and define either clinical, radiographic, biochemical, or even initiation of hormone therapy for any reason. And the secondary endpoint of this trial is listed here. So basically, again, the SBRT arm are superior in terms of progression-free survival, biochemical-free survival, and so this is a 4th, although phase 2, but it's a randomized control trial, proving the concept that SBRT is very effective in patients with oligometastasis. So this is my summary slide, but it's hard to believe that in this era we complete this presentation without talking about immunotherapy or combining immunotherapy with SBRT. And exactly like what I mentioned about the oligometastasis concept is well known almost 100 years ago. The concept that immunotherapy fight cancer, or our immunity fight cancer, is well known more than 100 years ago. There's a surgeon called Dr. Cooley's who noticed that if the cancer patient get infection and his immunity start fighting the infection, in fact, the cancer disappear. So he wrote this in the New York Times in 1908. And this patient with sarcoma, they injected him with toxins, stimulate his immunity, and he had good response. But this practice was aborted because minority of patient response to this, but also the lots of sepsis and septicemia. But the concept was well known a long time ago, and now we reinvent the wheel. So immunotherapy now is very successful, and result of SBRT is very impressive. So they start combining both and call it I-SABR. So this is, although exceedingly rare phenomena called abscopal effect, which means that you give high-dose radiation therapy to a site, then you have systemic effect or systemic complete response outside the field irradiated. This is a case published in New England Journal of Medicine. Memorial Sloan Kettering treated patient with spine SBRT. Then with follow-up, all the lesions disappear. The right paraspinal lesion, the right hilar, the liver, and splenic metastasis disappear. And they believe that this is immune-related. So the interesting thing about this publication is it's one patient that was case reported and 21 authors. So let's talk about the cancer immunity cycle. So we know that, briefly, this is my last maybe 2 or 3 slides. So we know that typically, we want the release of cancer cell antigen. Then after that, we want the antigen-presenting cell, like the dendritic cell, to present this to the lymph node, stimulating the priming and traveling of T-cell lymphocyte, which goes through bloodstream all the way to the tumor. Then the last 2 steps is infiltration of T-cell, and T-cell need to recognize the tumor and need to kill the tumor. So this is the cancer immunity cycle. You need all the steps for your immunity to fight against cancer. Problem is our immunotherapy work here and here. So the CTLA4 checkpoint inhibitors work here. The PD-1 inhibitors, PD-L1 inhibitors, and CTLA4 work here. So nothing work in the first two steps. And we believe that SBRT might work in this first 2 steps. The lack of drugs that work here explain why minority of patients respond to immunotherapy, so-called primary resistance to immunotherapy. So if we give high-dose SBRT, for instance, like this patient, we think that the SBRT induced something called immunogenic cell death, which means that the cancer cell antigen will be released. Then this also enhanced the dendritic cell or antigen-presenting cell to present this cancer cell antigen into the lymph site, and this also will increase the production of cytokines and alter the tumor microenvironment. So my last 2 slides is the fact that this table summarizes some of the published trial to prove this concept. Unfortunately, 2 of those trials was already published and a negative trial, but still, at least this 2 table listed 18 randomized control trial ongoing to test the concept of combining high-dose radiation therapy or radiation therapy with immunotherapy. We know that hopefully it worked. We know the story of durvalumab, although it's given subsequently after radiation therapy for stage 3 non-small cell lung cancer is working very well. So hopefully we can have a good result. This is my my summary slide. So we know that colorectal carcinoma is very common. Oligometastases describe a clinical phenotype of limited metastatic spread. And the reported randomized phase 2 trial are very encouraging, but randomized phase 3 trial are ongoing. And combining SBRT with immunotherapy might improve the immune response. This was my last slide, and thank you very much for your attention.
Thank you, everybody. And I think that I would thank all the presenters and would like to have, if any questions. I mean, Dr. Akwa and Dr. Fida and Dr. Gahtani, can you come to the stage, please? So maybe I will kick the ball, and my question to Dr. Akwa.
تفضل دكتور
Go ahead.
جواد.
Assalamu alaikum. I'm Dr. Jawad Busbih. I'm consultant gastroenterology and advanced therapeutic endoscopy at King Fahd Hospital. I would like to thank all the speakers for a nice talk, and I would like to congratulate Al Musa Hospital for really an excellent event. My question to my colleague Dr. Abdurrahman, do you use endoscopic ultrasound for all patients before doing ESD? This one. Second, since you are not doing, you are not closing the defect with clubs after ESD, do you used to do margining with diathermy coagulation or not? My question to Dr. Ahmed Akwa, we know that one part of the screening test is a fit test, which is as a screening program now established in our Saudi Arabia. So fit test, it is the sensitivity, it is 70 to 80% for cancer, but for adenoma, as you said, it's 24 to 30 or to 40. Do you think if we do dual test for fit test, do you think it's increasing the sensitivity instead of expose all patients to colonoscopy or not? Thank you.
Well, thank you for your question. For the first part, when you say, will EUS be used? You know, for colon, EUS can be advanced up to probably the proximal sigmoid colon. So the role for staging for endoscopic ultrasound in colorectal cancer is limited to the rectum and the sigmoid, and we don't do this modality if the lesion is more proximal in the ascending or transverse or descending colon. In our clinical practice, we do use EUS for staging for all rectosigmoidal cancer. For cancers that are more proximal, we send those patients for MRI. The advantage is that EUS is better than probably other modalities for T staging. It can define T3 lesion, and that's very operator dependent. You might send the patient says T2, the other says T3, so you really have to have a guy who is used to do the staging process for colorectal cancer. So that's the answer for the first question. Sorry, the second question was not clear. You were talking about the cutting margin or what?
Yeah, I mean the closing margin, you are not used to close the margin after endoscopic submucosal resection. Do you do coagulation, the margin, do you do diathermy or not?
Yeah, that's a very good question. Actually, we go around 0.5 centimeter from the margin of the lesion, and we put the dots, the coagulation dots. Then after that, we do cut with the knife across this, because this is going to give us a landmark when the lesion is cutting, what exactly the service that we have to cut. For EMR, it's not advisable to do coagulation after you finish the procedure. You better go and snare it and do a colonoscopy after 6 months, take biopsies and see. And for ESD as well, if you perform a full ESD for the lesion, you will have usually a negative margin. So we don't coagulate the margin for this. We just make sure that the base of the ESD is clean. There are no blood vessels that need to be coagulated. After that, you might clip it using clips, or you might stitch it using the suturing device.
Thank you, Dr. Jawad. I did not understand your question, Dr. Jawad.
Dual test, double fit.
You mean
Increase
at
the
the same
frequency fit test.
You mean at the same time?
at the same time or 6 months? Or at the same time, yeah.
Well, people are
Because
doing
there is
fit-
some studies now, they are doing the same times, and even in OMH now, it's recommended to do a dual test in the same time.
yeah, that's another issue. But all the society recommend doing fit test once as a standard test for screening. Dual test is not, it's not recommended, at least as in the guidelines.
Well, thank you all for the amazing presentation. My question for Dr. Amin. So we know that stereotactic treatment is usually delivering a very high dose to small field of radiotherapy. So what's its intake and what are your thoughts about the emerging hyperfractionated regimens that really have a stereotactic dose delivered to a larger port of treatment, like in fast forward to the breast and the colorectal cancer, where they have like 5 gray per fraction. So does that raise any flags or red flags, and do we need to take any extra precautions?
Excellent. So what was the question? Sorry, you're talking about treating larger volume with SBRT. Yeah, very good point. So you're absolutely right. When we start radiosurgery, we are very careful in selecting very small target, and there is size limit. But now we start expanding this and watching for the toxicity. And sometimes if the tumor is big, and last liver SBRT case that I did, the tumor was big, but patient running out of the option. So we minimize the dose. So we typically use 50 gray and 5 fraction for liver SBRT. This case I use 35 and 5. So what we usually do, we drop our dose, but at the same time, we tell the patient that the local control will drop from 80-90% to probably less, and we don't know how exactly less. But it's doable. It's doable, but you need to consent the patient about certain toxicity, and you explain to him that the local control is not going to be the 80-90%.
Thank you. I'd like to ask Dr. Gahtani, with regard, Dr. Gahtani, to those lesions, especially right now with the improvement in chemotherapy, and we are getting more and more patients who have a very good response. What do you do about those lesions that disappear? I know these are very problematic. Sometimes when you go in and these lesions have disappeared.
Thank you so much, Dr. Mamdouh, for this question, because as I have mentioned in the presentation, the complete pathological response is only 15%, but in spite of this, and in order to have more parenchymal sparing resection, if the lesions disappeared, we will do intraoperative ultrasound. If you cannot find any lesion by intraoperative ultrasound, I don't usually go after those lesions. I will just do what has been seen on the MRI or the intraoperative ultrasound, and then it will declare itself, or they will declare themselves later on down the road. If you have any appearing lesion later on, you deal with it accordingly. But I wouldn't do anything if I don't find it by intraop ultrasound.
With regard to the case of transplant for your patient for the colorectal cancer, I know it was not meant to be for transplant, but you've transplanted him because of the liver failure. But are there any studies, with regard to doing actually liver transplant for patients with colorectal cancer?
Yes, the problem with the liver transplantation, especially here in Saudi Arabia, is the donor pool. We have 30 to 40% of listed patients, they die on the waiting list. So barely you will have enough donor pool to transplant those patients with hepatocellular carcinoma and other end-stage liver disease. If you have more donors, yes, we'll do more of liver transplant for colorectal cancer liver metastasis. But there are some centers, but not here in the kingdom, they do liver transplant for those patients, because leaving them without transplant, the survival is less than 20 months. If you are talking about the survival of those patients who are not candidate for surgical resection or chemotherapy. If they don't have any other metastasis elsewhere, or if you can deal with the other metastasis and the patient is fit for transplant, usually they go for liver transplantation. Yes, the answer is yes, but not here in Saudi Arabia.
My question for Dr. Fidda, you know ESD is not widely available, only few centers can perform it. So first question, what are the criteria to refer patient for ESD, and how easy to do ESD post failure of EMR?
Yeah, that's very good two questions, thank you. So the criteria is that if you have a lesion that is between 3 and 5 centimeter, if the lesion is not sessile, if it's flat lesion or a little bit of depression lesion, then if the lesion is involving the submucosa by endoscopic ultrasound. So if it's only in the mucosa or the deep mucosa, EMR should be enough. And the second question was about?
How easy to perform ESD
Yeah.
post failure of
When we want to do an ESD for a lesion or even EMR, we ask our friends not to take a lot of biopsies, because taking biopsies is going to cause fibrosis at the area, and when we go resect submucosally, it's going to be more fibrotic tissue. The planes are not going to be clear. So if you are to perform EMR or ESD, you have to make sure that you want to complete it and finish it at the same session. If you are kind of doubting if you're going to do it or it's going to be difficult, then maybe taking one small biopsy superficial from the margin just for the pathology and send it for a physician who can perform EMR. But it's very much unadvisable to start an EMR, then stop it, then send it to somebody, or coming after a month and trying to do it from the first time.
Yes.
My question is for Qahtani or all the panel. With the complexity now of the oncology and the new modalities in terms of radiotherapy or surgery, did you establish or do you have a Saudi guidelines for the approach of patient with metastasis and a transplant, or it is center-based?
شكرا يعطيك العافيه ان شاء الله. طبعا the rule of transplant in Saudi Arabia, as I have mentioned to Dr. Mamdouh, is not yet established, or is not the standard. We have done it only in one case as a salvage procedure, because the patient was young, he was 35 years old, decompensated after resection of colorectal cancer liver metastasis. He was very sick in the ICU, and the only way to save his life is to get him a cadaveric donor at that time. So it's not the standard, but we did it as a salvage procedure.
Thank you. I have my last question to Dr. Qahtani. In case that, you removed one of the metastases to the liver and the histopathology came that positive margins, do you go again or you continue with the chemotherapy as usual?
Usually, I hate to say but really what I do with each patient, I usually send a frozen section. Because taking back the patient to revise a margin is going to be very difficult because of the formation of hematoma around the resection margin, adhesions, and it's going to be really very difficult to achieve a negative margin if you take the patient back after permanent paraffin section or permanent pathology. So what I usually do, I send the frozen section with each liver resection, assess it. I go myself downstairs with the pathologist, and if it's very close margin or positive margin, I usually revise the patient. It's very easy to revise it unless you have the margin which is very close or abutting a major vascular structure. If you take this vascular structure, that means the future liver remnant will not be enough. Then at this stage, I don't revise it. But usually, as a routine, I revise all margins. I send for a frozen section. If it's positive, it will be revised.
Thank you.
Okay, thank you everyone. We will conclude this session, and before we go for a short coffee break, we would like to present to our speakers just a appreciation for participating and in this conference and having honor us actually by being present. Thank you all very much. Dr. Ahmed Al-Akwa. Dr. Abdurrahman Al-Fada. Yeah. Dr. Muhammad Al-Qahtani. Dr. Amin Lamer. Dr. Hani Mustafa. Thank you.
ودكتور ممدوح نحوي.
Thank you very much. So we'll have a couple of minutes for a coffee break and then we will resume the second session for today. Thank you very much.
Good morning. We'll move now to the last session in colorectal cancer and in our oncology conference. We'll start by the first topic by Dr. Tariq Amin. Dr. Tariq, a well-known physician, he's senior distinguished consultant in surgical oncology at the King Faisal Specialist Hospital and Research Center in Riyadh. He studied medicine at Manchester University Medical School in the UK and trained in the UK, Canada, and USA. No, it's recorded. It's recorded. He apologized. Cannot. He has pioneered the introduction of cytoreductive surgery, hyperthermic intraperitoneal chemotherapy, HIPAC, in Saudi Arabia. Dr. Amin has also established a sophisticated intraoperative radiotherapy IORT program for advanced cancer surgery in Saudi Arabia. Dr. Tariq will speak about cytoreductive surgery, HIPAC, in metastatic colorectal cancer. The session is recorded and he will join us virtually in the discussion session.
Today I'm presenting on the role of HIPAC in colorectal cancer with peritoneal carcinomatosis, and will discuss my own experience at the King Faisal Specialist Hospital. Radical surgery is not enough. We know as surgeons that we can do radical surgery and adequate surgery, yet despite all our efforts, we still have a recurrence rate. This recurrence tends to be either metastatic, which we can do metastatectomy, but it's mainly in the realm of the medical oncologist and maybe the radiation oncologist. But mostly that concerns us as surgeons is the local regional recurrence and the peritoneal carcinomatosis recurrence. Most of these recurrence, that is about 80%, will occur in the first 2 years after the surgery. We can see here in this slide there are some high-risk features of some colorectal cancers that predict local regional recurrence and peritoneal carcinomatosis and the estimated 5-year survival. And we can see the 5-year survival is pretty low for all these features, despite the use of neoadjuvant and adjuvant chemotherapy plus or minus radiation. There are also features of the primary cancer that can predict local regional recurrence and peritoneal metastasis. And these rates are variable, and they can tell us whether we as surgeon can do anything that to try to reduce the local regional recurrence or peritoneal metastasis, as well as with the use of chemotherapy plus or minus radiation. One of the modalities to reduce this peritoneal recurrence or local regional recurrence is the use of cytoreductive surgery and HIPAC. And the basic element is the adequacy of the surgery, that it has to be complete cytoreduction to remove all visible tumor. If there is any small diseases left that is microscopic or small nodules less than 2.5 millimeters, and say on the serosal surface of the small bowel that cannot be removed, or on the large bowel, or on vascular structures like the IVC, then we depend on the hyperthermia and the intraperitoneal chemotherapy to eradicate the disease. As you can see here in one of my cases where I use an open technique and then close it with a plastic sheet, and then give a temperature of 41 to 42 degrees Celsius in the peritoneal cavity for at least 60 to 90 minutes. The hyperthermia allow the chemotherapy to penetrate the tumor nodules that are remaining and also kill the microscopic disease, as the hyperthermia and the chemotherapy are synergistic, and they on their own also can kill cancer cells. And because we're also using chemotherapy in the operating room setting, there are certain precautions we need to take, as you can see in the slide. HIPAC is not a course of chemotherapy. This is usually being confused. It is not competing with chemotherapy. It is a one shot, one dose only, and most of the dose is absorbed similar to a single IV dose. And this provides a physical and a chemical means of eliminating microscopic disease at the time of surgery due to manipulation, spillage, or that spread that is already occurring at the time of surgery. So it is an extension of the surgery to clear as much of the tumor as possible, to reduce the incidence of recurrence. The potential advantage of the intraperitoneal chemotherapy at the time of surgery is that there is no adhesion. We lyse all the adhesions, and we have access to all recesses of the peritoneal cavity, eliminate floaters, and deal with microscopic disease. The extent of the cancer is variable, and therefore the extent of the surgery is also variable. This can vary from gastrectomy or a colectomy or an appendectomy to multiple organ resections or multivisceral resections, and from partial peritonectomy to a total peritonectomy. So the complication and morbidity mortality is variable. The types of tumors are variable in different series, and therefore the surgical procedures are also variable and depend on the tumor. And this is in addition to the variable characteristics of the patient as well. But all the studies show that the peritoneal cancer index is a measure of the extent of the disease, and the lower the extent of the disease, the better the survival. By implication, this means that early referral of the cancer is important rather than multiple courses of treatment and progressive disease. Also, the completeness of cytoreduction depends on the extent of the tumor, but largely on the technical skills of the surgeon. And this depends on the learning curve. We need about 240 cases to be called proficient in cytoreductive surgery and HIPEC. And also, we need to perform between 30 to 50 cases per year to keep our skills up and judgment also to a high level. Also, the importance is the chemosensitivity of the cancer cells. This does not just apply to systemic chemotherapy, but applies also to intraperitoneal or bidirectional chemotherapy that is being used. The natural history of colorectal cancer is well documented from the EVOCAPE study in the late 90s, which shows a median survival of 5.2 months. With the advent of chemotherapy, the survival has improved by at least 30%, as you can see in the blue box. And then with the advent of cytoreductive surgery and HIPEC, the first phase 3 trial in the Netherlands shows less than doubling of the survival in 5 years. And the patient treated with cytoreductive surgery and HIPEC, but this was 5-FU-based chemotherapy. There are many other studies which show significant improvement with HIPEC treatment until the Prodigy 7 trial came out and showed no benefit to the addition of HIPEC in patients who undergone cytoreductive surgery and chemotherapy. But the Prodigy 7 trial has many problems. As you can see in this slide, the 5-year survival is of 41.7 median survival is 41.7 months, and the relapse-free survival is quite miserable at 14 to 13%. But what we can say is that the addition of oxaliplatin HIPEC, again, oxaliplatin HIPEC for 30 minutes, again, for 30 minutes, on top of cytoreductive surgery does not influence both the overall survival and recurrence-free survival. But the trials also showed that the PCI is of importance, as indicated in the previous slides, and also a subset of patients with a PCI of 11 to 15 do benefit from the addition of HIPEC to their treatment. The Prodigy 7 trial, you can see there are many hospitals participating, and as I mentioned, with the learning curve and the volume, Many of these hospitals have a very low volume compared to some of the major centers. This could explain some of the results, from especially regarding morbidity and mortality. Also, when the same group of hospitals performed HIPAC for gastric cancer, but in this trial, only 30% of the patients received oxaliplatin chemotherapy and the rest non-oxaliplatin chemotherapy, and this showed a significant improvement in survival with addition of HIPAC to the treatment. Also, there are several series who were published on complete cytoreductive surgery alone without HIPAC to treat colorectal peritoneal metastasis. And we can see that the 5-year survival varies between 18 to 28%. These are lower than the Prodigy 7, but similar to many of the other studies that are published. When we looked at comparative studies with internal control, comparing systemic therapy alone versus systemic therapy and cytoreductive and intraperitoneal chemotherapy, we can see they all showed benefit to the addition of cytoreductive surgery and intraperitoneal chemotherapy. But notice the results from the French group is significantly higher in both arms. And then this comes to the issue of maybe there is an element of patient selection. All these trials used chemotherapy in an adjuvant setting. Therefore, we need to look at whether the addition of neoadjuvant chemotherapy to patients who are undergoing cytoreductive surgery and HIPAC would confer any benefit. In this review by Hani Youssef, published in 2017, the evidence was not there, and further trials need to be made to see the benefit of neoadjuvant, but it cannot be determined at that time. Another more recent review in 2022 by Michael Flood came to the same conclusion. It is not sufficient to curtail the use of neoadjuvant chemotherapy. The practice remains heterogeneous, and prospective randomized trials are needed to assess its benefit. When we look at all the trials that looked at HIPAC in both the treatment modality or the prophylactic variety, we can see the ones in the green that have been published did not show any benefit to HIPAC. But you can see that all the trials used oxaliplatin and for 30 minutes, which is now has been discounted. Unfortunately, some of the trials that are still pending are using oxaliplatin, and I'm sure they will not come with a positive result. And many of the trials are also using mitomycin C as a monotherapy, which is problematic, as I'll explain later. In this article from the Journal of Clinical Oncology, there are other articles came up to the same conclusion, that patients with colorectal peritoneal metastasis or advanced local disease who received FOLFOX treatment as the main treatment for this disease, they had difficulties in showing any benefit with oxaliplatin-based HIPAC. In fact, when they tested the cancer cells for sensitivity to oxaliplatin HIPAC, it was found that only 18% of the cells were sensitive to the oxaliplatin HIPAC. And this could explain partly the failure of the Prodigy 7 trial. Also, when we look at the hyperthermia and the duration, we can see in many experiments that were done, it shows that the temperature of 43 for 60 minutes, it can kill 90% of the cells by the heat alone. And when the temperature is at 40 degrees for 30 minutes or less, only 10% of the cancer cells are killed. And therefore, this could also explain partly the problem of the Prodigy 7 as other problems are also regarding the binding to protein and to blood during surgery of the oxaliplatin to this protein will not make it available to the cancer cells. The benefit of the Prodigy 7 is that it allowed all HIPAC centers to look at their protocols for HIPAC. And in fact, this was positive in that 78% of centers increased their perfusion time from 30 minutes to 60 to 90 minutes. And also many centers abandoned the use of oxaliplatin to non-oxaliplatin regimen. The use of chemotherapeutic agents in HIPEC is under more intense study now compared to the past. Also, when we look at the culture of organoids, it was found that they were not very sensitive to heated oxaliplatin or mitomycin monotherapies and do not achieve their eradication. And in fact, that monotherapy are unlikely to be as effective in HIPEC as we previously thought. And in fact, that the patients with peritoneal metastasis from colorectal metastasis are mostly of the CMS4 molecular subtype, which is the mesenchymal type. These kind of subtypes do not benefit from the addition of oxaliplatin to adjuvant therapy, and also have the worst prognosis of the 4 subtypes in this classification. In fact, Dr. Sugar-Baker published also in 2022 an editorial, and there are other articles who have the same opinion, that the durable clinical response for mitomycin C for colorectal cancer is about 20%. But if they use HIPEC with the concentration of the drug that is increased, and also with the hyperthermia, you can increase this response to around 40%. And therefore, it's not surprising that 30% is the long-term survival expected with cytoreductive surgery and HIPEC for colon cancer peritoneal metastasis when they're treated with mitomycin C, which is the predominant modality currently. And in fact, if you look at several series, the 5-year survival in most of them is around 40% or less. But this is not all doom and gloom. Also, a recent systemic review and meta-analysis of several thousand patients, including the Prodigy 7 trial, showed that in fact that cytoreductive surgery in HIPEC can improve the survival rate of patients with colorectal cancer peritoneal metastasis. Also, the recommendation for HIPEC for colorectal peritoneal metastasis continues to be in many of the national guidelines and in many practice guidelines, as shown in this slide of the American Society of Colon and Rectal Surgeons. When we looked at colorectal cancer in Saudi Arabia, I found an article in 2015 published by Dr. Sana, which showed patients referred to the King Faisal and patients from non-King Faisal Specialist Hospital who had early or regional disease, and the 5-year survival varied from about 30 to 55%. This was at the same time when we started our HIPEC program in early 2009. We looked at 52 patients from that period up to September 2015. We did not include appendiceal cancer and did not include patients with extra-abdominal disease. And we can see that the vast majority of the patients received mitomycin C as a monotherapy. And the disease-free survival, as expected at 5 years, is only 29.2%, which is consistent with the paper of Dr. Sugar-Baker in 2022. When we looked at the patients who had recurrence, that were 34 patients, 25 of them had abdominal metastases. And when we looked at the 5-year survival, we could see that we obtained a 5-year survival of about 50%, which is compatible and pretty good compared to other trials that also have been published at that time or earlier. When we looked at the patients, we found that very few patients are offered cytoreductive surgery in HIPEC. The vast majority have been referred after failed multiple lines of systemic therapy. Late treatment of carcinomatosis is a current status, and most patients did not receive adjuvant chemotherapy, contrary to what is quoted in the trials. And therefore, we decided to look at changes in the intraperitoneal chemotherapy to improve the results with plus and the addition of IRT in certain selected patients. When we look at the regimen we used earlier on, as in this previous study just quoted, the ones above the red lines are the treatment that we use. For colorectal cancer, we use either melphalan or mitomycin C, mainly mitomycin C, but more currently, since 2015, we've been using a much more intensive regimen, and the one we use mainly for colorectal cancer is cisplatin, 100 milligram per meter square, combined with mitomycin C, 30 milligram per meter square. Then we looked at our cancer registry to see the results, to compare our treatment of HIPEC to the patients who did not receive HIPEC. And therefore, this paper, which has been published in 2022, looking at population-based survival for cancer patients in Saudi Arabia for the year 2005 to 2009. And I operated on some of these patients, or a significant number, and our 5-year survival was 52% for colorectal. This improved slightly from 44.7% at 1994 to 52% by 2009. And when I look at the patients with metastatic disease, which currently that's what I'm dealing with, as now I do not deal with primary colorectal cancer, my colleagues in colorectal cancer do deal with it. And remember that peritoneal carcinomatosis has a worse prognosis than patients with either lung or liver metastases. I've done well over 600 HIPEC procedures, so therefore I looked at the first 450 patients whom I followed for many years to assess the response to the treatment. I do a variety of tumors, but I've included 122 colon cancer and 15 rectal cancer patients. We did 2 HIPECs in 35 patients and 3 HIPECs in 5 patients, and we use IRT in 163 patients, but mostly the non-colorectal cases. When we looked at our overall survival for all the cancers, we can see our 5-year survival rate was 60%. This is really quite an excellent result. And when we looked at our failure rate in the first 2 to 3 years, it was 25%. This is contrary to the 85% I indicated in the first slide of my presentation. So this is also a significant improvement. When we looked at the completeness of cytoreduction, we can see that there was a significant improvement with complete cytoreduction. And then we looked at the colon cancer patients. Now remember, I'm dealing with patients who have a 5-year survival of 20%, 21% or less. And we have obtained a 5-year survival of almost 60%, which is quite a significant improvement. And when we looked at the completeness of cytoreduction, the numbers are too small to compare, because the vast majority of the patient had complete cytoreduction, that is 105, and only 17 did not have a complete cytoreduction. And we looked at cancer of the rectum. This is a small number of 15 cases. We did not get many cases referred to us initially, but now we're getting more cases referred, and we're doing them in collaboration with our colorectal colleagues. And we can see the 5-year survival is just under 50%. This is much better than 21% survival, but with rectal cancer, the survival is even worse than colon cancer. So this is a significant improvement. When we looked at the completeness of cytoreduction, only 1 rectal patient did not have a complete cytoreduction. The vast majority had complete cytoreduction. And when we looked at all the cancers, including the colorectal, we can see with the changes of the intraperitoneal chemotherapy to more intensive regimen, and with the addition of IRT in some selected patients, we have significantly improved the 5-year survival for all patients. Thank you.
Moving along the HIPAC track. We have Mr. Hakim from King Faisal Specialist Hospital in Riyadh. Clinical pharmacists are the gatekeepers for the safety of delivery of chemotherapy, and he will join us virtually.
Arnari, don't open the door!
Mr. Hakim?
Yes?
Hello?
Who? Yes, hello?
You can start. We hear you. Just share your presentation and we hear.
I'm still disabled, I believe.
Yes, go ahead.
Okay, thank you very much. I would like to thank the organizing committee for this invitation to present about cisplatin association with nephrotoxicity in patients undergoing cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, which is known as HIPIC, which is intended to treat patients with carcinomatosis from variable tumor origin. Before I do so and proceed, I would like to reveal that I have no type of conflict of interest to the topic that to be discussed here in this presentation. Now, cisplatin is a metallic platinum with a square planar geometry. With this chemical advantage, it's very tiny, small molecule, and when it gets reaching an aqueous environment, this chlorine atom will be replaced by a water molecule, and that will turn the platinum atom with a potent hydroelectrophilicity characteristics, inserting itself in the DNA strand. And that will lead to inhibiting the separation of the DNA and the process of coiling. And that ultimately the DNA will not be able to replicate. In addition, it has alkylating process, so the alkyl group will be attached to the guanosine, and that also will prevent the process of the multiplication in the cell. It's one of the oldest medications that's been used in the oncology paradigm. It was approved by the FDA in 1978. And it was used efficiently in treating variable types of tumor, including ovarian cancer, testicular cancer, and small cell lung cancer. Now, one of the problems of the use of cisplatin, nephrotoxicity, besides other complications like myelosuppression, ototoxicity, and some neurological problems. However, nephrotoxicity was always looked to it as the dose limiting in patients receiving cisplatin. The vast majority of evidence coming or describing cisplatin nephrotoxicity actually is coming from the medical oncology paradigm, where the patients receiving cisplatin receiving in a consecutive cycles That's what he means, that the patient is receiving accumulative doses of cisplatin, and the incidence of nephrotoxicity here ranges from 20 to 35%. Now, patients, unfortunately, who develop nephrotoxicity from cisplatin, they will be at higher risk of mortality, because actually the patient will be deprived from receiving appropriate cisplatin at a good time. Also, they might be undergoing adjustment of the doses with actually no fair evidence to describe the dose adjustment and how that will impact the outcomes of the chemotherapy. Now, there are actually many theories try to explain the nephrotoxicity induced by cisplatin, including the inhibition of the fatty acid oxidation and necrosis and apoptosis, tubules of the kidneys, or it might be related to the inhibition of the DNA in the mitochondria, similar in the way as it inhibits the nuclear DNA. Now let's move to the cytoreductive surgery and HIPIC, which is the other part of this presentation when we try to link it with cisplatin nephrotoxicity. Now, I believe Dr. Tariq fairly described the aim or the basis of the HIPIC. Simply, there are some theories try to orchestrate why HIPIC could be introduced as a treatment. First, it might permit the use of high doses, because the application of chemotherapy here is local, is not systemic initially. And also heating the chemotherapy will increase the aggressiveness or the cytotoxicity of the chemotherapy. Besides, heat itself might also has anti-cancer activity by promoting the white blood cells and the natural killers to the site of activity. And also application of the chemotherapy immediately after the major cytoreduction and exposing the micronodules, which actually most of the recurrence come from these micronodules if the macro tumor was resected fairly. Now, if we're gonna go to cisplatin use in HIPIC, there's actually various regimens has been used in HIPIC. Unfortunately, the doses were not even among the literature that described cisplatin use in HIPIC. So we have a wide doses range, ranging from 15 milligram up to 150 milligram per meter square. And even at some centers, that if we're gonna take like the 100 milligram as the standard dose of cisplatin application in HIPIC, some centers, they vary from other in the perfusion time, which ranges from 30 to 120 minutes. And I believe Dr. Tariq just elaborated about one of the major drawbacks of the Prodigy 7, that they only infuse the oxaliplatin over 30 minutes. Now, the NCCN, they recommended for patients undergoing HIPIC and using cisplatin to use the 100 milligram per meter square. Now, there's actually a phase 3 trial that was published in the patient with epithelial ovarian cancer, and showed that combining HIPIC with cytoreductive surgery yielded prolonged survival compared to use cytoreductive surgery alone. And this was the positive phase 3 trial, and also there are some observational trial in the peritoneal mesothelioma and gastric cancer, which are considered fair to use HIPIC in those type of patients using cisplatin. Now, from the initial time of introduction of HIPIC, there were concerns about, does the chemotherapies leak, or how would the chemotherapy behave after stripping the peritoneum? Now, therefore, many pharmacokinetic trials actually were published since year 2003. So in this trial showed that conducted by Rossi, and they showed that the AUC, the area under the curve, of the perfusion compared to the plasma area under the curve, almost only 1/20th or the 20 times the perfused AUC was higher than the plasma AUC. Now, even during the time and year by year, there were also more publications describing the pharmacokinetics of different chemotherapeutic agents used in HIPEC. Now, we have this trial that was just very recently published by Casimora and his colleagues with Draco. It was phase 3 trial comparing how would the pressure in the abdomen will affect the cytotoxicity of the chemotherapeutic agents, based on the theory that the increasing the pressure, the intra-abdominal pressure, would increase the cytotoxicity of the chemotherapy. However, the results regarding the pressure were comparable, but I'm not bringing this pure surgical outcome here in this presentation. Our intent here to see how that affected the area under the curve. So they used cisplatin 42 milligram per liter of the perfusate besides mitomycin C. And most of the surgeons, the application of the amount of the perfusate ranges from 1.5 liter to 2 liters. Most of the patients had the peritoneal pseudomyxedema peritoneae. And as similar to the results seen in year 2003, the AUC of the perfusate compared to the plasma was almost at very close range, ranging from 25.2 and 22.5, regarding both patients received HIPEC, but at different intra-abdominal pressure. Now, in the study, the landmark trial that showed the superiority of the HIPEC with CRC versus CRS alone, in this trial, they applied the 50% of the dose at the start of the perfusion. Then, after 30 minutes, they applied the 1/4 of the dose. Then, after 60, at the minute 60, they applied the final quarter of the total dose. And that was also combined with sodium thiosulfate to attenuate the nephrotoxicity with the use of cisplatin. Now, most of the centers are actually trying to apply this split doses in a way just to maintain a steady concentration in the abdomen. And that was actually the outcomes of the phase 3 trial that showed that the survival was improved up to 45 months in the intervention arm compared to the CRS or the surgery alone. Now, the problem when we look to this landmark trial from a toxicity point of view, the author unfortunately did not perform a statistical analysis regarding when it comes to each adverse effect. Now, in the patients who underwent surgery, 2 patients actually developed nephrotoxicity, which is constituting 1.6%, and no patients progressed to grade 3 or 4 nephrotoxicity according to the assessment of the cytotoxicity scale. Now, patients who had HIPEC, actually there were 4 patients who developed nephrotoxicity, almost 5%, and 1 patient progressed to severe renal impairment. Now, when we look to the literature about the nephrotoxicity observed with cisplatin, it ranges from 4 to 40%. That's actually the wide range. And most of the description about this nephrotoxicity after the HIPEC and cisplatin developed at was observed at day 3 post-surgery and peaks at day 5. And it's associated with a severe hypomagnesemia. Now, many HIPEC surgeons, they believe that the impacts of the chemotherapeutic agents could not be explained solely or attributed solely to cisplatin. First, because there's actually the pharmacokinetics trials that we're accumulating showing that the amount of cisplatin reaching the systemic circulation is very low. And even from the medical oncology paradigm, it's very rarely that a patient who develops nephrotoxicity from the early dose or the first cycle of chemotherapy, though over there they're giving the chemotherapy is reaching at 100% bioavailable. Also, in regimens that not using cisplatin, nephrotoxicity was also observed at a range reaching up to 38%. Now, in the cytoreductive surgery, actually, it actually induces a sort of renal hyperperfusion. We are talking about the major debulking surgery and cytoreductive surgery there is a massive fluid shifts between the intra-abdominal and the vascular system, and that would affect the kidney function. And there's a massive cytokines production leading to severe depletion of the intravascular volume and organ hyperperfusion. So this might be one of the factors that could affect the development of nephrotoxicity in patients undergoing HIPEC. Now, in King Faisal Hospital, that we published our outcomes in year 2014. We started our case in the year 2008 with a dose of cisplatin of 50 milligrams per meter square plus doxorubicin 15 milligrams per meter square. At that time, most of the HIPEC surgeons and the regimens globally were a bit conservative when it comes to the dosing of cisplatin. And by building the experience, more centers accommodated larger doses of cisplatin. Now, we accommodated the rifle criteria to quantify our, or to describe our nephrotoxicity when using cisplatin. We included 53 patients in this study. We took all the patients who had HIPEC from November 2008 up to November 2013. Two patients actually among the 53 patients had AKI. One patient met the failure criterion of the rifle criteria, and that patient unfortunately progressed to chronic renal failure. The other patient had only the injury criterion of the rifle criteria and recovered fastly. When we looked further to the patients who had the renal impairment, we found that the patient who had renal impairment, they were receiving angiotensin II converting enzyme inhibitors. And this is well known that these agents are in patients of hypoperfusion status. They might exaggerate the impacts on the kidney function. Besides, the patient who had nephrotoxicity had lower urine output to begin with in the day one and in the day of the surgery. Now, in order to improve the outcomes, many centers try to look to maneuvers to help in reducing the renal impairment, like using sodium thiosulfate. And in this French group, they use sodium thiosulfate, similar in the way that was used in the phase 3 trial. So they combined cisplatin, doses ranges from 50 to 100 milligrams per meter square. And this was actually one of the major drawbacks because there actually no even dose of cisplatin was applied. And they came with the results that in a patient, in 11 patients of the 35 who had underwent HIPEC with cisplatin without sodium thiosulfate, the 11 patients had a nephrotoxicity, while none of the patients who received thiosulfate had a nephrotoxicity. There's the mechanism behind how thiosulfate actually reduced the nephrotoxicity is not well described. However, theoretically, it might be a way to induce inactive cisplatin metabolite formation, and that would reduce the concentration of cisplatin reaching to the kidneys.
Mr. Hakim,
Now,
you have
on
2
the other
minutes.
hand,
Mr. Hakim, you have 2 minutes.
Okay, I'm completing it after this slide. Thank you. In Australia, Alonso, they again applied the same regimen of thiosulfate with cisplatin, and they found that 36% of the patient developed renal impairment, though the thiosulfate was applied. Finally, in a study that tried to assess the use of different chemotherapeutic agents and other factors in the development of renal impairment in patients undergoing HIPEC, they shown that using cisplatin was a risk factor for developing nephrotoxicity in patients with HIPEC. So in conclusion, cisplatin is a commonly used chemotherapeutic agent in HIPEC. Knowing the safety profile of its use is of paramount importance. Nephrotoxicity is not uncommon after cytoreductive surgery with cisplatin and develop at variable rates, and causal relationship is difficult to conclude. Nephroprotective agents used in cisplatin to protect from kidney dysfunction continue to be debated. We need more studies to assess the use of sodium thiosulfate as a renal protective. Thank you very much for this opportunity you gave to me, and thank you very much.
Thank you, Mr. Hakim, for this nice presentation. We have a minor adjustment in the program. Now we'll go to the last presentation by Professor Ali Shamsuddin. Virtual. Dr. Ali?
تسمعني؟ الو الو
Hello?
نعم عم تسمعني؟
Yes. So it
Yes,
gives me a great pleasure to introduce Professor Ali Shamsuddin. He's professor of clinical medicine, director of gastrointestinal genitourinary cancer program, Basil Cancer Institution at the American University of Beirut, Lebanon. He's a pioneer medical oncologist in the region, specialized in treatment of GI and GU cancers. Dr. Ali will speak about locally advanced rectal cancer, total neoadjuvant therapy, TNT, versus chemoradiation. The mic is yours.
Thank you, Ahmed. I will share my slides. So do you see the screen?
Yes, yes.
Okay, so my task today is to talk about locally advanced rectal cancer and what is the outcome of both and the difference between total neoadjuvant therapy versus the conventional chemoradiation. This is my disclosures. So the current outcome for locally advanced rectal cancer as follows. The 5-year local relapse rate is 5 to 10%. And thanks to TME and radiation, and specifically with the use of neoadjuvant chemoradiation to markedly decrease the local recurrence, but still the pathologic CR less than 20%, so more than 80% will need surgery. And as you can see that always they die from distant metastasis with a 65% disease-free at 5 years and 70% 5 years overall survival. As a cancer specialist, our aim is to extend the overall survival of these patients by reducing metastasis and avoiding local recurrence, and improve quality of life by avoidance local recurrence, stoma, late effects, specifically the sexual and incontinence effects, and maintaining the functions. So in rectal cancer, when we try to discuss any case, it's always a combination of different approach like radiation therapy, chemotherapy, and surgical intervention. And always it is important to base the decision based on the MRI that will explain the detailed features of the disease, specifically the presence of CRM involvement or the extramural vascular invasion and the lymph node involvement. And accordingly, we select the type and the sequence of therapy. So our agenda today will talk about the achieving local control in rectal cancer through different treatment approaches, and the role of adjuvant chemotherapy in rectal cancer, moving from adjuvant to neoadjuvant chemotherapy, and why total neoadjuvant is one of the standard of care nowadays, and what will be the future approach when we use the chemoimmunotherapy. So the local control always optimized, as you can see here, by improving in the staging using the MRI specifically to decide on the involvement with rectal fascia and the lateral pelvic lymph nodes, and the improved surgical techniques with well-trained colorectal surgeon to apply the successful TME, beside the quality control of TME through the pathology. They have to inform us about the quality of this TME, whether it is a complete or incomplete, and also include the use of perioperative standard of care long course chemoradiation. There are factors that affect the local control, distant metastasis, and factor can affect both. As you can see here, the local control mainly came from the advanced T, or if you have a low-lying tumors, while distant metastasis mainly from the positive extramural vascular invasion by MRI and the positive nodal involvement. And in between, we have the involvement of CRM or the advanced T stage, specifically the T3. Remember that part of the rectal cancer, as you know here, will not need radiation therapy. This part, specifically the upper rectal cancer, as you can see from two big trials, the Swedish rectal cancer trial and the Dutch rectal cancer trial. In both trials, they showed that patients with high rectal cancer, when you compare preoperative radio followed by TME versus surgery alone, there is no significant improvement in the or decrease in local control. So maybe the upper rectal cancer, as you can see, you may omit the use of radiation or chemoradiation and you go directly for surgery. What is the difference between the short course radiation, long course radiation therapy, specifically in local control? And these are the three main trials that compare both short course and long course: the Polish 1 trial, the TROG-0104, and Stockholm 3 trials. And you can see here, after 4 years follow-up, there is no difference between local control between short course and long course radiation therapy. And this is a meta-analysis of all data based on comparing short and long course radiation therapy. And you can see there is no significant difference in death rate, local recurrence, complication, distant metastasis between both the short course and long course radiation therapy. Why short course radiation is more convenient and less costly? Because the patient is coming only for 5 days from Monday to Friday. So it is more convenient for the patient, specifically if he is working. and if his inhabitant, his house is away from the hospital. And also it is means that less time will be spent in the hospital, specifically in the COVID exposure. And the cost, as you can see, there is a significant difference between the cost estimated in the United States for long course as $19,311, while in the for long course, while the short course, the cost is $7,311. But sometimes we prefer to use the long course, specifically when our strategy for watchful waiting is desired, or when we need a maximum control of the local disease, specifically for low-lying tumor, to prevent the AP resection. What is the role of adjuvant chemotherapy? The data for adjuvant chemotherapy came from Gunderson trial, which is a phase 3 randomized trial that tried to find whether chemotherapy is significantly improve outcome versus observation. And this is an old trial using only 5-fluorouracil. But remember, in this trial, most of these patients, we did not use MRI for staging. So some of these patients overstages to stage 3, while actually they are stage 2. And it is before the era of TME, which is significantly improved the outcome in these patients. When we add oxaliplatin and in the adjuvant setting, there are several trying to examine the effect of the FOLFOX or CAPOX in the adjuvant setting versus single agent 5-fluorouracil. And you can see here, there are the German trial, the PITAC6, the ADOR and Carrington trials, and all trials did not show any improvement in 3-year disease trial, except the German trial. And you know that the German trial, they have their own exceptional protocol when they use the oxaliplatin on weekly basis, different from the other trials. And a recent follow-up for the German trial showing that the benefit of the patients in the German trial for significant improvement of 3-year disease-free survival only for patients below 60 years. As you can see here, 78% versus 67%, while no difference in PCR, as you can see, only 16%, which is the standard for all these trials, but there is no benefit above the age of 60 years. This is also the adjuvant chemotherapy in a meta-analysis for all the European trial that try to examine the effect of the adjuvant chemotherapy, the 4 European trials. As you can see here, more than 1,000 patients. There is no improvement in overall survival in this meta-analysis, but remember that the only positive is the finding in patient with a high rectal cancer. There is an improvement in disease-free survival and distant recurrence in favor of the use of adjuvant chemotherapy. So you can see that the upper rectum behaving like colon cancer. And this is why the trend now in upper rectum may be to avoid radiation therapy. So if the compliance with chemo is suboptimal, why not to give the chemotherapy operatively in total neoadjuvant? In patients with the conventional therapy, you can see that 27% of eligible patients locally advanced rectal cancer never start adjuvant chemotherapy due to surgical complication. And there is always delay in the chemotherapy beyond 3 months. And every delay beyond 4 weeks will carry a chance of increased mortality by 14%. And there is always less than 50% of the patient who receive the full course of chemotherapy or the full dose of chemotherapy. And subsequently, from all the trials, there is no improvement in the overall survival. So the strategy to move forward is moving chemotherapy before or after radiation, but before surgery. In node-positive patients, in patients who are fit, it means below 70 years, and in patients with good performance, in patients with CRM positivity, and in advanced T3, specifically T3C and D, or a T4 lesion, specifically T4A, excluding the T4B patients, and keep the standard preoperative long-course chemoradiation for a T3 low-lying tumors, followed by surgery and the chemotherapy post-surgical depending on pathology. Why total neoadjuvant therapy also? From the physics, radiophysics, you can see that after the long course chemoradiation, there is increase in the incidence of PCR. The chance of PCR increase with time, and you can see the maximum PCR achieved for patients when they can be observed more than 12 to 14 weeks after radiation therapy. So delaying surgery beyond the standard of care, which around 6 to 8 weeks, will give more patients with PCR. And this data came from the National Cancer Database in the United States. Also, retrospective data of a pooled and 14 studies, more than 3,000 patients, and also from MD Anderson showed that patients who are downstage to pathologic PCR, complete response, they have a significant improvement in survival, as you can see here. So this is why the idea of moving to total neoadjuvant therapy. And from our hospital at the American University of Beirut, we published our data last year for the total neoadjuvant versus the standard of care. As you can see here, around 81 patients, 55 representing around 68% received the standard chemoradiation, and we have 26 representing 1/3 of patients receiving TNT. As you can see, the TRG downstaging as pathologic complete response, although it is numerically more with our patient who is receiving TNT reaching 38% versus chemoradiation 27%, but the p-value was not significant because of the low number of patients. And the 2 years survival, there is no difference between both groups, but you can see that there is significant improvement in the compliance of chemotherapy, more in favor of TNT received the full dose on time for about 85% of the patient versus only 40% that received chemoradiation with significant p-value. And also we have the data came from MD Anderson, the randomized from Memorial Sloan Kettering by Garcia Aguilar. This is a phase 2 randomized trial, compare the standard chemoradiation followed by observation surgery versus 3 arms, either in between the chemoradiation and surgery to give 2 cycle FOLFOX versus 4 cycle versus 6 cycles. And you can see here there is significant improvement in pathologic PCR when the patient received in interval chemotherapy with 6 cycle FOLFOX, reaching PCR 38% versus standard of care, which is 18%. And you can see here there is significant improvement in progression-free survival, a disease-free survival after follow-up 58 months, significantly improved, but actually the survival did not improved with this category of patients. So what type of total neoadjuvant always we go for, whether the interval chemotherapy, this means starting by chemoradiation followed by the chemotherapy and surgery, or the consolidation or the induction chemotherapy, start by chemotherapy, followed by chemoradiation, or followed by surgery. And this was answered from the phase 2 randomized trial. This is the German trial, try to answer these questions. And the primary endpoint is try to increase the PCR from 15 to 25%, and they call it pick the winner. So pick the winner is a phase 2 randomized trial, more than 300 patients randomized to either induction chemo followed by chemoradiation and surgery, or chemoradiation followed by interval chemo therapy, which is around 3 cycles of FOLFOX followed by surgery. And you can see that the primary endpoint was in favor of the chemoradiation followed by chemotherapy followed by surgery, with a pathologic CR reaching 25% versus 17% and significant p-value. Also, you can see that the compliance to chemoradiation, the grade 3 toxicity, and the full dose of radiation was in favor of the induction chemoradiation followed by chemotherapy and surgery. And also the dose of the chemotherapy, dose intensity with FU and oxali appear to be more significant with the interval chemo or consolidation chemo followed by, that means chemotherapy followed the chemoradiation. Also, we have the phase 3, the Polish 2 trial. This is a phase 3 randomized trial, try to answer the question. It is more than 500 patients comparing the short course radiation followed by 3 cycles of FOLFOX versus the standard chemoradiation. And you can see this is the first trial that showed improvement in overall survival at 3 years with significant p-value.
But still have 3 minutes.
Yes.
3 minutes.
I think we need more. Sorry. Okay. So we'll try to, and recently we have the Rapido trial and the Prodigy trial. And these 2 trials try to answer the role of TNT, either using the short course followed by chemotherapy and surgery, or the chemoradiation followed by surgery, or using the triplet chemo followed by chemoradiation and surgery. And you can see that also there is no benefit in survival in the Rapido and Prodigy trials, but there is an improvement in distant reduction in metastasis and improvement in disease-free survival by 7%, and also pathologic complete response in both from 12 to 28%. There is no impact of chemotherapy on the outcome in this category, and also there is no impact of the chemotherapy or on improving the surgical techniques. And so chemotherapy in TNA does not appear to make surgery easier or increase stability, and does not reduce local recurrence. The Stellar trial is the Japanese trial aiming for the same idea, and it also showed the improvement in disease-free, but no improvement in overall survival. The idea of chemoimmunotherapy is try to change the immune desert tumor to immune inflamed tumors. And using this, we have our data from avirectal trial presented in ESMO GI, and also you can see there is significant improvement by using chemoimmunotherapy following short course radiation therapy in PCR reaching 37%, while TRG1 and 2 in our trial reaching more than 67%, as you can see here. And also we have what they call immunoscore that showed a significant improvement and correlation with PCR in our trial, with a significant p-value 0.036. And this immunoscore also showed in our trial significant improvement in 3-year disease survival, reaching 85%. So I will try to conclude with this statement. A stratified approach to resective rectal cancer is feasible. Remember that around 30% you may not use radiation therapy in this, specifically the upper rectal, so you go for TME followed by adjuvant. They behave like colon. In the rest of the colon cancer, rectal cancer, 60 to 70%, we need the multimodality approach. Radiotherapy, either chemoradiation, is preferred in some patient with a patient with a low rectal cancer, but total neoadjuvant approach should be explored as an alternative approach in patients with a high risk of distant metastasis, specifically the positive node T4, advanced T3, patient with CRM positivity or extramural vascular invasions. And chemoimmunotherapy following short course should be explored in larger trials. Thank you for listening, and I will stop here.
Thank you, Dr. Shamsuddin, for this excellent presentation.
Bismillahirrahmanirrahim. It's my pleasure to introduce Dr. Nidal Bukhari, who is attending consultant medical oncology, King Fahd Specialized Hospital, Dammam, as well as assistant professor in Imam Abdurrahman bin Faisal University. Dr. Nidal, specialty is gastrointestinal and genitourinary malignancy. He did his residency in Western University. He did his medical oncology fellowship in McMaster University. Dr. Nidal will speak about treatment sequences in metastatic colorectal cancer.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى صحبه وسلم. Thank you very much, Dr. Abdulaziz, for your kind words. Thank you, Dr. Ahmed, Al Musa Hospital, and the organizing committee for inviting me to this great event. I'm honored and delighted to be with you guys. I hope you learn something new. I see surgeons, radiation oncologists. This is a purely medical oncology topic. I will try to entertain you as much as I could, but no promises, guys. And by the way, don't shy away from reminding me with time, because it's a huge topic. So I'm going to talk about treatment sequencing in metastatic colorectal cancer. This is the outline of my presentation. I'm going to go over statistics, standard of care, and first, second, and third line treatments. I'm going to go over the relevant biomarkers we need prior to choosing the most appropriate treatment. I'm also going to go quickly over the biologics and the recent role of immunotherapy in metastatic colorectal malignancies. Before I start speaking about colorectal cancer, we know that it's the third most common cancer globally. It is the second cause of cancer death. Unfortunately, 20%, 1/5 of patients present with metastatic disease at presentation. Unfortunately, more than 50% of patients presenting with early disease will end up having metastatic disease no matter what you do. These dismal numbers are from the American Cancer Society, which is based on SEER database. Unfortunately, it's the 5-year survival rate for stage 4 colorectal cancer remain at 11%. So what's the standard of care in as of November 2022? Those tables from NCCN guidelines that you're all familiar with have grown significantly over the last 15 years. And inshallah will continue to grow for the sake of our patients, inshallah. But irrespective of the sizes of NCCN, ESMO, ASCO guidelines, there are certain factors that we rely on prior to choosing first-line treatments and subsequent line of treatments, including patients' comorbidities, cancer-related biomarkers. 5 or 6 years ago, we also learned that sidedness matter. So this slide here rhymes with what I just mentioned in the previous slide. You see the right upper corner there where it says molecular characteristics. This will continue to grow and it will expand by next year. Those biomarkers are the most important biomarkers we order prior to choosing or starting first-line treatment. No matter where you come from, governmental hospital, private sector, these are the biomarkers that I would like to see prior to starting chemotherapy plus a biologic or sometimes immunotherapy. RAS status, KRAS and extended NRAS, BRAF mutations, which is alhamdulillah way less than the incidence reported in Western studies. And we're going to talk about that inshallah. MSI high tumors represent 5% of all metastatic colorectal cancers. Sidedness matters. So I have to admit that when the data of sidedness came out in 2016, I was not initially a strong believer, probably due to some of the anecdotes I had in my practice who responded very well to anti-EGFR in first line. But with time, with accumulating evidence, I have converted. My practice is totally based on sidedness and biomarkers in first line and sometimes in second line setting. These are different tumors. They have different prognosis. They're heterogeneous they have molecular heterogeneity, which is significant. They also, according to SEER database, have worse prognosis. This is based on a review done from 2000 to 2012. And as you can see, the lines, the orange lines and the yellow lines have significantly lower overall survival than left-sided cancers and rectal cancers. All the trials that came later on were consistent with what was mentioned in this review. Two things we have to know throughout the journey of treating metastatic colorectal cancer. You will end up losing patients. So 1/3 won't be fit for second-line treatments. The other thing, further you go through treatment, response rate to systemic treatment drops significantly. What about backbone chemotherapy? This question was asked 20, 15 years ago, and multiple trials have answered these questions. They concluded the following: there is no difference with starting either lines in first line or second line. Starting FOLFIRI or FOLFOX is the same in first or second line. Okay, so this usually depends on comorbidities, patients' preferences sometimes, but the bottom line is it does not impact overall survival. What about a triplet? So for you guys, radiation oncologists and my dear surgeons, FOLFOXIRI, I'm not sure if you keep hearing about FOLFOXIRI in clinic. FOLFOXIRI versus FOLFOX plus bevacizumab followed by maintenance 5-FU bevacizumab was looked at in TRIBE study. This is the most famous trial that looked at triplet versus a doublet. It was positive. The primary endpoint was overall survival. A clear overall survival of 4 months was observed in the experimental arm, which was a triplet plus bevacizumab. There are lots of trials that actually showed consistent results, such as VISNO, STEAM, VOLFI-2, which looked at a triplet plus an anti-EGFR versus a doublet plus anti-VEGFR. However, it comes with a cost. I typically don't use a triplet in first-line setting. It's extremely toxic, and a lot of patients will hate you for doing this. I will use it only in fit patients who have potentially resectable disease. So where does the evidence from chemo plus bevacizumab, doublet plus bevacizumab come from? From long time ago, Horowitz trial looked at adding bevacizumab to irinotecan plus 5-FU and compared it to 5-FU plus irinotecan. A survival advantage of 5 months was observed with the irinotecan based plus bevacizumab based treatment. That also applies to FOLFOX plus bevacizumab. What about anti-EGFRs? Anti-EGFRs are meant for patients who are KRAS, BRAF mutated. Many randomized phase 3 trials have actually looked at the use of anti-EGFR such as cetuximab or panitumumab plus doublet chemotherapies in first-line setting, such as CRYSTAL, PRIME, FIRE3, Taylor trial. Crystal Taylor Fire 3 looked at a doublet plus cetuximab. Fire 3 compared FOLFIRI-cetuximab to FOLFIRI-bevacizumab. They were all in favor of adding an anti-EGFR to first-line treatment. That applies to panitumumab as well. FOLFOX plus panitumumab is superior to FOLFOX. FOLFOX plus pani versus FOLFOX plus bevacizumab also resulted in a significant overall survival advantage exceeding 12 months. This systematic review published by Arnold back in 2019, I believe, included 6 randomized phase 3 trials and concluded that anti-EGFR plus chemotherapy is effective as first-line treatment in patients who have primary left-sided. That's why left-sidedness matter. Those agents are ineffective in primary right-sided colon cancer. As a matter of fact, this systematic review concluded that it may be associated with a detrimental effect. The most recent evidence is from ASCO 2022 in Chicago. Again, the results of panitumumab plus FOLFOX plus bevacizumab. FOLFOX was in favor of the panitumumab arm in the overall population and in left-sided colon cancer. The 36 months, 48 months, 60 months survival were all consistent and in favor of panitumumab plus FOLFOX compared to bev-FOLFOX. So we conclude that in primary left-sided metastatic colorectal cancer, chemo plus anti-EGFR is the standard of care in first line. What about this different entity, the microsatellite unstable patients? So Keynote 177 took patients who are microsatellite unstable and randomized them to either pembrolizumab versus the investigator's choice of chemotherapy. There were actually primary endpoints such as progression-free survival and overall survival, and other key secondary endpoints. The trial was in favor of pembrolizumab in first-line setting in terms of PFS, PFS2, overall survival. Interestingly, KRAS wild type and BRAF wild type benefited from immunotherapy according to this first plot. So strongly positive trial based on the latest update presented a few months ago. Do we have other alternatives for MSI high tumors in first-line setting? Yes, we have. Nivo-Ipi, based on Checkmate 142, a phase. However, the level of evidence is less here. It's derived from a phase 2 trial. Checkmate 142 was a multi-cohort trial where cohort 3 included patients who were not previously treated and gave them nivolumab and ipilimumab. Excellent response rate, 13% had CR, and it is now an acceptable treatment in first-line setting in patients with MSI high. Again, MSI high cancer patients represent 5% of metastatic colorectal malignancies presenting to the clinic. I'm going to switch gears now and move to second-line treatments. So, how do we actually base our decisions? This is mainly based on previous lines of chemotherapy, tolerance of previous lines, previous targeted agents, mutational status. BRAF matters more in second-line treatment. I'm going to tell you why. Sidedness may play a role as well. So bevacizumab could be used in KRAS mutant patient based on TLM trial. TLM is a phase 3 trial that randomized patients to either a different line of chemo plus extended bevacizumab. Primary endpoint was overall survival. This trial was positive. It extended overall survival by 2 months, I believe, and was statistically significant. So bevacizumab in second line is a standard of care in patients that are who are KRAS mutant. What about continuing an anti-EGFR in second line? I think that's one of the most controversial topics in GI oncology. Do they benefit from extending an anti-EGFR, or would they actually benefit from switching them to bevacizumab? Most of the evidence we have is in favor of changing the treatment to an anti-EGFR. So if these patients were KRAS wild type and progressed on first-line anti-EGFR chemotherapy, the typical practice is to change them to Avastin plus a different line of chemotherapy. SPIRIT trial was a trial that looked at, that tried to answer this question with the primary endpoint of PFS and other secondary key points such as overall survival and objective response rate. It was in favor of bevacizumab plus chemotherapy. It was not statistically significant according to the trial, but we have other trials that actually had evidence consistent with what was actually presented by SPIRIT. Unicancer Prodige 18 was a very interesting trial. These are patients who are KRAS wild type and received previous bevacizumab plus chemotherapy for some reason, okay? So these patients received bevacizumab, chemotherapy, even though they were KRAS wild type. And those patients were randomized to either cetuximab plus chemotherapy-based treatment versus Avastin chemotherapy, continuation of Avastin plus chemotherapy. PFS was the primary endpoint, 4 months PFS and overall survival. Interestingly, surprisingly, the overall survival benefit and PFS benefit was in favor of continuing bevacizumab in second-line treatment. There are two issues with this trial, right? The first issue is a significant proportion of patients did not have BRAF testing. And we know that anti-EGFRs actually are ineffective in BRAF mutated cancers. That's number one. The other thing is extended NRAS was not done in a significant proportion of patients in this trial. So you may take the results with a grain of salt, right? Are anti-EGFRs effective in second line for primary right-sided metastatic colorectal cancer? So prior to that, I was referring to left-sided cancer. I'm gonna speak now about right-sided metastatic colorectal cancer in second-line setting. Again, the evidence is controversial. I'm not aware of any trials that strongly advised or concluded the benefit of anti-EGFR in second-line setting. As a matter of fact, the retrospective review done on CO17 patients, the Canadian trial that looked at cetuximab in third line, actually showed that patients with right-sided colon cancer did not gain any benefit from subsequent line cetuximab-based treatments. So no one will blame you for not using an anti-EGFR in second-line setting for primary right-sided colon cancer.
دكتور نضال 3 minutes.
3 minutes؟ طيب إن شاء الله أخلص قبلها بإذن الله تعالى. BRAF mutated, Beacon, looked at encorafenib, binimetinib, cetuximab in BRAF mutated cancer patients. Alhamdulillah, as I said, we reviewed our patients in Dammam. It's not as the number of BRAF mutated patients is way less than what was mentioned in the literature, is around 1.5% for 5 years. The trial was positive in favor of a doublet instead of a doublet and a triplet. So an arm had a triplet, doublet plus chemotherapy, cetuximab, encorafenib, binimetinib had a superior overall survival. What about immunotherapy in second line? Pembrolizumab is known to be effective in subsequent lines of treatment. MSI, we know that from 5 or 6 years ago. It is in the guidelines. You can use it in second-line setting. Nivo-Ipi is also a good alternative in MSI high tumors in second line. What about third line? You guys all have regorafenib, a multikinase inhibitor that's used in third line setting. Correct trial. TAS-102 is also another kid in the block that emerged in the last 3 or 4 years. It's a life-prolonging third-line treatment in colon cancer. Adding bevacizumab to TAS-102 improves survival according to the Danish trial. The concept of re-challenge, I'm not in favor of it, and I can answer any questions that could come on that regard. These are biomarkers that we should consider asking. I'm ordering HER2 anyways on patients. The proportion of patients with HER2 positive disease is extremely low in my practice. So in summary, first line, chemo plus anti-EGFR is the standard of care for primary left-sided metastatic colorectal cancer, KRAS BRAF wild type. Chemo-Bev for right-sided metastatic colorectal cancer or KRAS mutant. Immunotherapy for MSI high tumors. In second line, chemo-Bev and KRAS BRAF wild type. Immunotherapy if not previously given. In third line, we have TAS-102 plus minus Bev or regorafenib. Clinical trial, if possible, and possibility of re-challenge in some patients. And with that, I conclude. I would like to thank you and thank the moderators and Dr. Ahmed again.
Thank you very much, Dr. Nidal, for this rich, full talk. I will leave now the mic with my colleague, Dr. Majid.
Our last speaker is Dr. Shakir Sadadi. He's an American board certified hematologist oncologist and Yale University graduate coming from Ibn Nafis Hospital in Bahrain. Dr. Shakir.
Assalamu alaikum. First of all, I would like to thank the organizer for inviting me, and also I would like to congratulate people of Al-Hassa for this new cancer center, also the owners. وبعدين الله يسامح دكتور احمد خليتني اخر واحد. احنا اليوم الانتخابات البرلمانيه في البحرين، فانا قلت اجي اول واحد عشان لا يقولون انه طالع في نفس اليوم بعدين يقول لك يعني يصير مشكله. عموما probably we served the best thing for the last. انا I will be very شو اسمه very quick. وهذه الدقيقتين اللي قلت هذه لا تحسبونها من أول شيء ولا حد يطلع لا نشتكي عليكم. عموما اليوم today I will talk about the circulating DNA, which was a topic given to me, and it is interesting actually. My outline will be generally I will talk about the anyway I will talk about introduction to circulating DNA, use in adjuvant setting, metastatic setting, also in MRD. I just want to say about the gold standard for NGS for diagnosis is the tissue biopsy. But tissue biopsy have its own limitation, which include the turnout time. Usually with tissue biopsy, with the NGS, it comes about weeks, but circulating DNA maybe days, 7 to 10 days. Always the pathologist will say there's insufficient tissue. This is always happening. Sample acquisition, difficult to take a biopsy from certain places. And also with the tissue biopsy, we cannot study the intramural and temporal heterogeneity. The potential uses of circular DNA is in diagnosis, treatment response, resistant, measurable residual disease. And we have two kinds I will talk about is the tumor-informed and the tumor-naive. Tumor-informed that you need a tissue before to be sent and then you take the blood. The tumor-naive is the circulating DNA from the blood and usually measure the epigenetic signature and methylation marker. There have been a lot of studies and analysis. One of them is the Godzilla study that when you see that identification of actionable mutation with the circulating DNA almost 100% in different cancer of the GI compared to less than that, and also the timing is maybe 11 days compared to 33 days. There's various clinical application platform which include metastasis, finding a resistance, screening, and the MRD. This is a full slide showing that we can use the circulating DNA in different platforms from metastasis to MRD to screening even and acquired resistant. What's the comparison between circulating DNA and tissue-based? Basically, circulating DNA, quick time, minimal invasive, capture tumor heterogeneity, and temporal monitoring, and detection of early disease. But the limitation is being more technically challenging for fusion protein. We'll talk about that. This is a good, interesting slide. Actually, you can, with circulating DNA, even before the imaging, you can detect early if you see. I don't know how to make the, anyway. If you see in the top with the imaging, compared to circulating DNA, you can detect earlier, and also after surgery or after chemotherapy, presence of circulating DNA correlate well with the recurrence rate. And also, if you clear the circulating DNA, you don't have a recurrence. Just one information about the tumor-informed and tumor uninformed. The tumor-informed, you have to have the tissue before diagnosis, and then you use the blood again for the analysis, and this is being used in the MRD basically, where is the only the blood, which is the circulating DNA, which is called the liquid biopsy. You use it for resistant, for acquiring mutation, and this is the main difference actually. So, clinical basis, this is the NCCN guideline for stage 2, mentioned before, colon cancer. Stage 2, when it comes to you do T3, T4, then the clinician comes to the clinic, whether I give adjuvant, not give adjuvant. This is based on clinical situation, which include lymphovascular invasion, perforation, lymph node being taken, and you give chemotherapy. If not, you observe. Despite that, 15 to 30% of patients stage 2 also, they still have recurrence. Circulating DNA has emerged not only as a prognostic marker, but also potential for a predictive tool to guide the treatment. And this being observed in many studies, observational study, which include the regional Galaxy observational study, which basically said that those who have surgery from stage 1 to stage 4, oligometastasis, when they have circulating DNA, the disease-free survival is less. When you clear the circulating DNA with chemotherapy, their disease-free survival increase. This led us to this is a new article, June 22, which also published in ASCO, and that was the preliminary discussion this year, that circulating DNA analysis guide adjuvant chemotherapy. Basically, they took probably 250 patients that they randomized T3 to T4, they randomized to 2 to 1, managed according to cycling DNA management or standard management. Plasma specimen were obtained from circulating DNA analysis for all patients at 4 and 7 weeks. Patient with positive cyclic DNA result, either 4-7 received adjuvant chemotherapy. The primary endpoint was recurrence-free survival at 2 years. You can see this is a secondary endpoint. You can see in the second line that 15% with those who have cyclic DNA, they have less chemotherapy compared to 28%. So the study showing that we can use less chemotherapy with cyclic DNA. And this is really an interesting study. And you can see from subgroup analysis in the right that less chemotherapy being used with those patients who have cyclic DNA. And the primary endpoint is non-inferior study. You can see the disease-free survival on 2 years and 3 years. They are non-separable. So it's an inferior study for the first time that you can use a circulating DNA to guide you in the terms of adjuvant chemotherapy. And I'm not going to be surprised in the new days ahead, they will put it in the clinical staging system for those with colon cancer. Also, not only that, those who are negative DNA at 3 years, they have recurrence-free survival more than those who have positive DNA, and you can see it from the graph. So what's the other use of circulating DNA is monitoring of MRD. With the origin in the word hematology, the minimal or molecular or measurable residual MRD in the context of colorectal cancer often refers to cyclical DNA. Has emerged a powerful marker predicting which patient with colorectal cancer are likely to relapse, because its short half-life, ranging from minutes to few hours, allows more accurate and real-time dynamic measure of disease burden. This has been studied in different, and you can see from this, the more circulating DNA from stage 1 to stage 4, you have the recurrence risk-hazard ratio increase compared to those who have low circulating DNA. This is the same slide I talk about, just to talk about tumor-informed and uninformed. These four pathologies. The tumor-informed, less timing, the tumor uninformed, less timing, 7 to 10 days compared to weeks. The four main up differences. You use tumor-informed genomic and tumor-uninformed genomic and epigenomic. You don't have a tissue for liquid biopsy for tumor uninformed, and you don't have tumor testing also for tumor uninformed. When for the timing, usually 2 to 4 weeks after curative surgery or any surgery, even for metastatic. Repeat testing is suggesting patient with undetectable circulating DNA within the first 4 weeks of resection to avoid false negative. Even because the DNA declined very quickly on effective systematic treatment, in the surveillance setting, circulating DNA for MRD at least 2 to 4 weeks after even completing adjuvant chemotherapy. What about early recurrence? This is also an important topic. So the NCCN guidelines, ASCO guidelines, in terms of follow-up, use the CEA, colonoscopy, clinical exam for the first 5 years. Sensitivity of CEA is less than 70%, but it's still used. Circulating DNA has been shown to predict relapse in colorectal with a median lead time of like about 9 months, even before the for the imaging, which is very interesting. And also, just one word, monitoring of recurrent is distinct from MRD. This has been a lot of study, recent study, which is published. Some of them, they are publication in ASCO a couple of years ago, these years, and showing that monitoring longitudinal follow-up of circulating DNA correlate very well with the early recurrence. What about metastatic disease? Being mentioned, I will just a few words on the metastatic disease. It's an emerging tool, adjuvant tool, in addition to imaging in response prediction. The last line, a 4-week change in circulating DNA was predictive of clinical benefit and prognostic of outcome with improvement in progression-free survival in patients who receive chemotherapy and they demonstrate more than 30% clearance of circulating DNA. This was mentioned before. We know that in microsatellite unstable or DMR, that when you use pembrolizumab, they have better free survival. We know that from previous study. But still, there is 30% of patients were refractory to pembrolizumab. So early identification is very important. Who is with non-responders, with the use of circulating DNA. And you can switch if you know that these patients have not responsive. This being studied in a few studies, phase 2 trials, like INSPIRE study, a prospective phase 2 trial that followed 94 patients with 25 advanced solid tumor types treated with pembro with serial DNA. And you can see that in the blue line, if you clear your DNA, that your overall survival is almost 100%. In the black line, if you decrease the clearance, also you have a better survival. But in the red line, if you have increase in circulating DNA, your overall survival worse. Not only that, you can see the red line. These are the decreased DNA. They always have either complete remission from radiology, partial or stable disease. But the blue line with increased DNA always have progressive disease. What about, this is very important, what about acquired resistant clonal evolution? We know that single lesion biopsy is ineffective in estimating underlying tumoral molecular heterogeneity. And emergence of resistant subclones either within the same lesion or in various metastatic sites in an individual patient using repeated tumor biopsies is difficult and practical. So circularly has a potential to identify emerging genetic alteration. This being studied in the anti-EGFR. Unlike what the doctor said, I'm just saying that you have heterogeneity. This is what the slide showing. You have a targeted therapy like anti-EGFR, you use it and then you become resistant to it and you have progression of disease. You stop it and then you can, what's called holiday, and you can reuse it again. So circular, we have to identify those who have, they can respond with the same anti-GFR. This is called clonal decay. You can use the same molecules after even using it in the first time. So this being studied, this is a study, patients who initially had a response to anti-EGFR therapy were allowed to re-challenge if circulating DNA test, if DNA did not reveal a mutation or that in the mitogenic activation protein kinase. Another one, and RAS and BRAF, you can see in the right, those who have wild type by using circular DNA, they have a better free survival compared if they are not a wild type, and even overall survival. This is just a slide which tell you that the tumor mutational burden assessment circular DNA are different from in terms of different molecules. I don't know how it goes. And just a few words on this NTRK fusion molecule. It's a targetable mutation. I don't know whether Hamid, you've done it or not, but this is in 5% of GI cancers. But I just mentioned that it's difficult to use the circular DNA in detecting this mutation. Usually the immunohistochemical staining better and NG is better. But if you're gonna use the circular DNA, it's better to use the RNA because it gives you the signature for that. Thank you for that.
Thank you, Doctor, for this excellent presentation. And now we have time for a couple of questions. Please, speakers, can you please come? And if we can, yes, with Dr. Ali Shamsuddin and Dr. Tariq Amin. تفضل.
Okay, thank you for all the speakers for a nice, really excellent lectures. My question for Dr. Shakir Sadadi, regarding the cyclic tumor DNA, it's a timing you say it should be done after surgery. So I wonder why it's not before surgery and before resection. And the other, it's very useful, should be done for all patients or just only for familial colonic cancer?
I listened to the second question. It's for all patients actually. Circulating DNA represent a liquid biopsy, and there are situations, actually I use it myself, I'm not sure about here. There are some situations where you need to use it because it's difficult to, especially for metastatic disease, difficult to take a biopsy from the original, or maybe difficult to study. So it's not related to the genetic or familial. And I didn't understand the first question.
The first timing you said it should be done, the timing of cyclic tumor DNA after resection, is it?
Yes.
So
yes.
why it shouldn't be done before?
Before
So
no, what's the reason you are doing it before? Because you have already the tumor. The reason you're doing after to assess the minimal residual disease, in case just you have early recurrence and you can give chemotherapy, because it will be present, circular DNA, any tumor you have it before, it will be present. So after resection, it should be cleared.
Hello? Dr. Tariq, is Dr. Tariq with us? Any other question?
Okay, I will. Please speak.
السلام عليكم. I'm دكتورة منال, Assistant Consultant Medical Oncology, حمد الجبر Oncology Center, حسن. My first question to Dr. Ali, in case of TNT, what after surgery if no pathological complete response? Second question to Dr. Nidal, in case of microsatellite instability high, and if we use Nivo EP in first line, what is the second line after disease progression? Second question, any role for immunotherapy, pembrolizumab, in case of unknown MSI in first line or beyond?
You want me to take them first or Dr. Ali? طيب, for بصراحة the level of evidence for excellent question Dr. Manal. The level of evidence for pembrolizumab in first line setting in MSI high tumors is higher. So I would stick with pembrolizumab instead of ipi-nivo. But if you're stuck or you're in desert island where you don't have pembrolizumab and you only have nivo ipi, it's totally acceptable. If I use nivo ipi or immunotherapy in first line setting, MSI high patients, I would probably discontinue it in second line setting, and I won't consider using any immunotherapy based treatments in second line setting due to the cross resistance that that is there. And I believe the first question is directed to Dr. Ali Shamsuddin.
Is Dr. Shamsuddin with us? No.
What was the question?
My question for Dr. Nidal regarding prognosis. So we know that patients with BRAF mutation have very poor prognosis, and also we know that patients with BRAF mutation also associated with MSI high. So what is the prognosis of these patients with BRAF mutation and MSI high in the era of first-line immunotherapy?
For some reason, KRAS wild type, BRAF wild type benefited more in Keynote 177. But it's a very tough question. Alhamdulillah, we don't have a lot of BRAF mutation in our practice. Typically, as you said, they do really bad. They are resistant to chemotherapy, no matter what you give them. Fulfoxiri, any intense treatment won't work. If I see a new BRAF mutated cancer patient in my practice, I will probably stick to a different class of treatment. If the patient has MSI high, or I would probably try immunotherapy-based treatment in those patients. صراحة. I know that the encorafenib cetuximab is more effective in second-line treatment based on the evidence we have, but we also have cetuximab, encorafenib, benimetinib that showed significant response in first-line setting in ANCHOR trial. We still don't have a phase 3 trial as far as I know, but I think that something will come up in the next year or two. And I hope that answers your question.
Any other questions? Okay, thank you all. So now we invite the speakers for recognition. Dr. Nidal and Dr. Shakir. Dr. Nidal. Dr. Shakir. And now the moderators, Dr. Majid, Osman, and Dr. Abdulaziz. With this, we have to conclude our meeting. I would like again to thank organizing committee, scientific committee, speakers, moderators, and Al Musa Specialist Hospital administration for the support. And hopefully we'll meet again next year with the second oncology conference at Al Musa Specialist Hospital. Thank you. And now we all invited to a lunch.